Good morning, everyone. Welcome to the third meeting on the Joint Interim Standing Committee on Health and Human Services. We will go ahead and proceed to roll call. Madam Secretary, please proceed.
Senator Nguyen?
Here.
Senator Titus?
Here.
Assemblywoman Brown-May? Assemblyman Gray?
Here.
Assemblyman Hibbets?
Here.
Vice Chair Orentlicker?
Here.
Assemblyman Nguyen?
Here.
And Chair Doñate.
And I am here. And we'll mark Assemblywoman Brown-May present when she arrives. She did mention to me that she'll be here a few minutes late. So welcome everyone to the meeting today for the Joint Interim HHS. Today is our Public Health Day. As I mentioned earlier during the interim when we first started, we were going to be tackling different priority areas, and today's focus is on public health. I don't know if there's ever been a HHS meeting specifically targeting only public health, and so it's really exciting to talk about different issues that will come up throughout the day. And it is also Eclipse Day, and so hopefully, if depending on when time goes quickly, I'll try my best to take a short minute break. If anyone brought their solar eclipse glasses, I didn't bring one, but maybe someone in the room did, and so we'll try our best to coordinate lunchtime around then. I do have a few housekeeping remarks. We do have a robust agenda today, and so just to go over, first I would like to remind everyone to please silence all electronic devices, especially for your cell phones during the meeting. For the members that are joining, please go ahead and mute your microphones when you are not speaking and leave your camera on. Additionally, I ask that presenters on the Zoom video call to leave your cameras off and microphones muted until I call up the agenda item under which you are present. Agenda items may be taken in a different order than listed, and then 2 or more agenda items may be combined for consideration. The committee's meeting materials can be found on the legislature's website. You can also sign up for the electronic notifications related to any activity on the committee's website. If you wish to testify in person, please sign in at the table by the door and leave a business card. And if you do not wish to testify, you may also want to sign in so we can keep a record track of you. When testifying in person, please turn the microphones on to speak and off to listen, because we have others listening to and viewing the meeting in Las Vegas and online. We will go ahead and start with public comment first. So if folks want to come forward for public comment, we will go ahead and limit public comment. Will be limited to 2 minutes each per speaker, and staff will go ahead and keep track. We also ask that folks do not repeat themselves so that we can allow everyone to have the chance to speak. I do want to remind folks that we do have a full agenda today, and we want to provide each topic sufficient time to be heard and considered. And you can always submit your public comment in writing if you don't have enough time to do so today. I am aware that there are folks that would like to provide their public comment in a different language today, in Spanish, so I'll make my just quick housekeeping remarks for them. Hoy sabemos que hay personas que quieren hablar en español, y si necesitan una traducción, aquí tenemos una persona que les pueden ayudar, pero nomás nos dicen cuando necesitan ayuda y ya después podemos empezar para que alguien nos pueda traducir las palabras. Let's go ahead and begin public comment here in Las Vegas. Mr. Kelly, please begin.
Good morning. My name's Patrick Kelly. I'm with the Nevada Hospital Association. During the last interim meeting, I listened intently to the discussion regarding the employment of physicians. As you proceed with your work, please keep in mind some important facts. 2.2 million Nevadans reside in primary medical care professional health shortage areas. Nevada is below the national average in 33 of 39 physician specialties. In 25 of those 39 specialties, the number of physicians did not keep pace with Nevada's population growth over the last decade. Our focus should be on recruiting and retaining more doctors, not limiting the employment options available to them. National trends can't be ignored. Nevada competes for physicians on a regional and national basis. One of the biggest and clearest trends is that physicians are leaving private practice or avoiding it. The American Medical Association published a study that concluded that physicians are continuing to abandon private practice in favor of direct or indirect hospital employment. In 2022, only 46.7% of doctors worked in wholly owned physician practices. That means that more than half of the doctors in America are not in private practice. Younger doctors seem to be leading this trend. Between 2012 and 2022, the share of physicians under the age of 45 who were self-employed fell by 13%. Younger doctors want a salary and a work-life balance. In 2022, 31% of doctors worked in practices that were wholly or partially owned by hospitals. An AMA analysis found that physicians are leaving private practice because of the need to negotiate better rates with insurance companies, the need to improve their access to costly resources, and the need to better manage regulatory and administrative burdens. And if Nevada wants to attract and, perhaps more importantly, prevent the loss of doctors, we need to recognize national trends and give doctors a variety of employment options. If we don't give them options, especially hospital employment, other states will. Thank you.
Good morning. My name is Leanne McAllister. I'm the Executive Director of the Nevada chapter of the American Academy of Pediatrics. Today, as you listen to state representatives give an update of Nevada's immunization rates and public health outreach efforts concerning vaccinations, I ask that you keep top of mind AAP's strong recommendation that all states eliminate laws permitting non-medical exemptions to school entry immunization requirements. Immunization requirements for child care and school attendance are an effective means of protecting people from vaccine-preventable diseases, both by direct protection from the vaccine and indirect protection via communal immunity. Immunization requirements also have a beneficial effect on timely immunization of children. Because rare medically recognized contraindications for specific individuals to receive specific vaccinations exist, legitimate medical exemptions to immunization requirements are important to observe. However, non-medical exemptions to immunization requirements are problematic as they create unnecessary risk to both individual people and to communities. The Nevada AAP currently has 280 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. Thank you.
Good morning, Chair Dunyate, Vice Chair Ornlicker, and members of the committee. Thank you for your time today. My name is Michelle Mayesse. I'm the president of SEIU Local 1107. We represent 20,000 workers in Nevada, and 704 of them are at Southern Nevada Health District. We are very excited to talk to you today about SB 118, and we are excited that this committee actually cares about the health and priorities of our community, as we know that a healthy community equals a healthy Nevada. We know that in order to have a good public health system and strong, healthy communities, we need a robust infrastructure. We need fully staffed public health workforce, because without the workforce, the services cannot be provided. As you know from the past and last time this committee heard, that we need to continue to support our frontline workers who kept this community safe during COVID-19, as well as on a daily basis. Whether it's with monkeypox outbreak, TB outbreaks, whatever goes in the workforce. In the last legislative session, SEIU testified on SB 118 to allow flexible funding that would be appropriated and used for local authorities, health districts to address our biggest infrastructure need, which is a lack of resources for the workforce. And we know that we want you to do more than just talk about it. We want you to retain, support, and sustain public health workforce so that it doesn't become a public health crisis. Addressing the workforce is vital and will provide the necessary services to support the healthy communities of Nevada. I want to thank our members, Regina, Lorraine, Sandy, Randy, Joy, Regina, and Blanca, who are here today to speak with you. Thank you for your time.
Good morning, Chair, Vice Chair, and members of the committee. Thank you for your time today. My name is Regina Ellis, and I'm a member of SEIU. I'm a registered nurse case manager at the Southern Nevada Health District. We understand that SB 118 establishes the public health infrastructure and improvement account and allocates monies to non-categorical funding to local health authorities on a per capita basis. This fund is for flexible funding. It can be used for what is needed. According to the 2021 Public Health Workforce Interests and Needs Needs survey of state and local public health agency staff in the U.S., the COVID-19 pandemic exacerbated existing public health workforce shortages. Nearly 1/3 of the public health workforce is considering leaving their organization in the next year. 50% are considering leaving due to pay. We're here today talking about recruitment and retention at the Southern Nevada Health District, and we think that prioritizing this will be beneficial to the citizens and the residents here at Clark County and in the state. 41% due to work overload or burnout. Can tell you that we were the front line for COVID-19. We worked for 3 years. Many people worked lots of overtime to protect the public, and we did not receive anything extra for doing that. There was no hazard pay. Some people worked lots of overtime, that were not compensated, but we did that because we're interested in protecting the people here in Las Vegas and the state. I work in the tuberculosis clinic. I want you to know that we've had a 40% increase in cases last year. We have not had a 40% increase in staff due to burnout and people leaving. I am currently the only case manager in the clinic, and our staff works very hard to protect the public from tuberculosis, which also goes
Ma'am,
hand in hand with...
If you can please finish your comments, please.
Okay. Which also goes hand in hand with HIV, diabetes, and some other illnesses. So thank you very much for your time. We're asking you to prioritize our public health services. Thank you.
Good morning, Chair, Vice Chair, and members of the committee. Thank you for your time today. My name is Joy Oliveros. I am a member of SEIU and also a senior community health nurse for the Southern Nevada Health District. According to the 2021 Public Health Workforce Interest and Needs Survey that was used for this bill, 50% of the public health workforce are considering leaving due to pay. As a community health nurse, I am witness to the high turnover due to this, and we appreciate the support of this bill to retain our current workforce. Thank you.
Thank you so much. I ask if there's other folks that want to come to public comment. If you can, let's go ahead and rotate them from the chairs. I think there's someone in Carson City, so if the folks from Carson City, if you can please proceed.
Good morning, Chair Doñate and members of the committee. Allison Jenko, Director of Nevada Government Relations for Dignity Health St. Rose Dominican for the record, here to testify in support of agenda item number 5 related to the presentation on public health needs and priorities to improve public health in Nevada. We are here to testify we testified in support of Senate Bill 118 during the 2023 legislative session, and just wanted to make sure our support was on the record for sustainable public health funding on the record today, and we look forward to seeing the outcome of this presentation today. We know that sustainable public health is needed in Nevada, and we want to make sure that comes to fruition this go around. So thank you for your time.
Thank you so much. Let's go ahead and continue down here in Las Vegas.
Thank you. Good morning, Chair, Vice Chair, and members of the committee. Thank you for your time today. My name is Rabia Sharif, and I'm a member of SEIU and an environmental health specialist for the consumer health section at the Southern Nevada Health District. I'm here to talk about personal vehicle use for field operations staff. Dining and tourism is our biggest attraction in Clark County, as we all know. We are the only county who serve and protect over 40 million people per year. That means our public health agency is working 24/7 to protect residents, including ourselves and families and visitors. Majority of field staff use their own personal vehicles every day for work and in their personal lives. Furthermore, staff are covering special events ranging from food operations, body arts, incident command, child care, nursing, home visits. These special events and unsuspected outbreaks are addressed in addition to maintaining our daily workload. All of this is done in our personal vehicles. A moment of transparency, I have spent at least $5,000 in a year between gas, brand new tires, brake struts, and oil changes. We need our personal vehicle allowance to continue to assist us with reliable means of transportation for business needs. The impact of wear and tear predominantly comes from work, which is at minimum 5 days per week, at least 8 hours a day. In case of an emergency response or special events, field staff can work up to 7 days and use their personal vehicles to accommodate business needs. So we call to request either Southern Nevada Health District provides us fleet vehicle support or financial stipend support towards our personal vehicle use. Once again, thank you for your time.
Anyone else in Las Vegas looking to do public comment? Si quieren hacer comentario público, este es el momento que pueden hacerlo. ¿Hay alguien en Las Vegas? ¿Pueden venir adelante? Si puedes puchar el botón para el micrófono y primer nombre y apellido.
Muy buenos días, mi nombre es Eduardo Moreno y soy un vendedor ambulante.
Good afternoon. My name is Eduardo Moreno, and I'm a street vendor.
Y no lo alcanzo a leer. En primer lugar, les agradezco bastante a las personas que nos pueden ayudar, apoyar y escuchar.
First of all, I thank everyone that is willing to support and listen to us.
Desgraciadamente no traje mis lentes, se me olvidaron por la prisa, pero ya había escrito un testimonio referente a los vendedores ambulantes. Sé que el Departamento de Salud tiene una cantidad específica para ayudar a los vendedores, y el cual no hemos visto ningún resultado. No sé qué sea.
I apologize because unfortunately I forgot my glasses, but I know that the health department has some funds available to the street vendors, and we still haven't seen use of them.
Y es que para el permiso que nos están pidiendo para los vendedores ambulantes, nos tiene muchas restricciones y los cuales no podemos nosotros, yo en lo personal no puedo solventar.
The permit that is required for street vendors, it has a lot of restrictions, and I personally something that I cannot afford.
Y por lo tanto, pues me gustaría solicitarles de la manera más atenta que si es posible que esos fondos puedan llegar a apoyar en parte para los costos de las solicitudes y se nos podrían proporcionar un carrito adecuado para poder vender nosotros nuestros productos.
And I'm here to petition if it's possible that some of those funds could be used to help with the cost of the applications for the permits, and also to afford a food cart that could assist us with it.
Entonces, no sé, es todo. Entonces, desgraciadamente, digo, no, tengo una lista muy larga, pero por las prisas se me olvidaron los lentes y no alcanzo yo a leer así.
And I apologize because I had a long list, but I forgot my glasses, and so I'm not going to be able to read it.
Pero la realidad es que las restricciones son muchas y la solvencia económica en lo personal es muy difícil, y pues me gustaría que esos fondos que hay, que nos los proporcionaran para poder apoyar a los vendedores ambulantes.
But the reality is that there are a lot of restrictions in place with all these permits. The economy is kind of difficult, so we were hoping that some of these funds could be used to help some of the street vendors.
Eso es todo. Muchas gracias por...
That's it. Thank you so much.
Lo siento por no poder haberme expresado correctamente como debería
Apologize
ser.
if I didn't express myself correctly as I was supposed to.
Gracias.
Thank you.
Muchas gracias, señor. ¿Alguien más que quieren hacer el comentario público en este momento? Por favor, adelante. Primer nombre, apellido, por favor.
Héctor Giovanni Arevalo. Soy un vendedor ambulante y pues yo quisiera parte de los fondos que se pudiera invertir en los vendedores que andan ambulantemente en las calles.
So, my name is Hector Giovanni Arevalo, and I'm a street vendor, and I was hoping that some of the funds could be used to invest in street vendors.
Realmente una cosa, ¿cómo me explicara? Que está costando mucho. Entonces, quisiéramos realmente una parte que fuera apoyo para nosotros, porque sí los está costando bastante.
It's something that I don't know how to explain it, but it's costing us a lot, and was hoping that the funds could help somewhat.
Oh, muchas gracias.
That's it. Thank you so much.
Thank you.
Muchas gracias. Además, ¿alguien más que quiere hacer un comentario público? No tenemos nadie aquí en Las Vegas, in Carson City. Is there anyone else in Carson City that would like to do public comment before we move online? BPS, is there anyone virtually?
Thank you, Chair. If you wish to provide public comment, please press star 9 on your phones to take your place in the queue. Again, if you wish to provide public comment, please press star 9.
Si alguien que está remotamente necesita hacer un comentario público, por favor presione la estrella 9.
Hi, Interim Health and Human Services Committee members. I'm Madeline Larson, a Master of Public Health student at the University of Nevada, Reno. As a student, public health is important to me because it includes the full picture of an individual and community's wellness. To achieve a state of optimal well-being for all Nevadans, providing sustainable and flexible public health funding is key. Throughout my studies at the University of Nevada, Reno School of Public Health, this type of public health funding is continually shown as one of the most important factors for promoting successful public health initiatives. Thank you.
Caller with the last 3 digits, 848. Please press star 6 to unmute yourself.
Name is Nereida Bobadilla. Hello, everyone. My name is Nereida Bobadilla, and I'm thrilled to be here with you today. As a member of Make the Road Nevada, this public health issue lies close to home. When I was just 3 years old, my family emigrated from Mexico to the United States in search of a better future. Life here has had its ups and downs. While my brothers and sisters that are American citizens can easily see a doctor when need be, it has not always been that simple for me. When I get sick, I can't always afford to see a doctor, and that can be really tough. What truly breaks my heart, though, is seeing kids who are battling serious illnesses like cancer. They go through so much pain and hardship that it is heart-wrenching to imagine what their families must endure. That's why I spoke up for SB 419, also known as the HOPE Act. This important law would have made a world of difference for people like me who struggle to afford health care. So you can imagine how disappointed I was when it didn't pass. It's scary to to think about people getting sick without good ways to get better. With Make the Road Nevada, I'm teaming up with friends, neighbors, and my community to make sure everyone, no matter who they are, can get the health care they need. Because let's face it, everyone deserves to see a doctor when they're sick without having to worry about money. So I ask you to join us in supporting legislation similar to SB 419. Together, we can make sure that healthcare is a right, not a privilege. Thank you.
Chair, the public line is open and working, but we have no additional callers at this time.
Thank you so much. I think we have one more in Las Vegas, so if you guys can come forward, please.
Buenos días, mi nombre es Gaudencia Torres. Estoy aquí hoy como miembro orgulloso de Make the Road Nevada, instando al comité a pasar legislación que proporcione atención médica a personas como yo.
Good morning. My name is Gaudencia Torres, and I'm here today as a proud member of Make the Road Nevada. And I'm in front of you guys to pass legislation to make sure that there is medical attention for people like myself.
Decisiones recientes, en particular la negación del gobernador Joel Lombardo al acta de esperanza.
Recent decisions, in particular the denial by Joe Lombardo, governor, on the Act of Hope.
Me han dejado profundamente decepcionada y preocupada por el futuro de la accesibilidad a la atención médica en Nevada.
It's got me deeply disappointed on the future that we have in the health for Nevada.
Ha sido una experiencia difícil encontrar cobertura médica. Solicité Medicaid, pero nunca recibí respuesta.
It's been a difficult experience to get medical coverage. I applied for Medicaid and never got an answer.
Ahora me encuentro con una deuda aproximadamente de $10,000 en gastos médicos.
So right now I have a big debt of approximately $10,000 in medical expenses.
Soy discapacitada y sufro de una enfermedad debilitante desde hace 30 años.
I'm disabled and I've been having a weakening medical condition for 30 years.
Llamada lupus eritematoso asociado con artritis.
Called erythematosus lupus associated with arthritis.
La negación del gobernador Lombardo al acta de esperanza fue una mala decisión.
The call from Governor Lombardo on the Act of Hope.
Esta ley, presentada durante la sección legislativa de Nevada en 2023,
Was a bad decision, a law that was presented during the legislative session in Nevada 2023.
tenía como objetivo proporcionar beneficios de atención médica a personas como yo.
The main objective was to provide benefits to people with medical needs like myself.
Que luchan por acceder a servicios médicos esenciales.
Who fight to obtain essential medical services.
Sin embargo, su negatividad ha dejado sin esperanza a muchas personas como yo que necesitamos desesperadamente cobertura médica.
However, his negative impact has caused a loss in hope for people like me that need medical coverage.
Mi experiencia personal resalta la necesidad urgente de atención.
My personal experience does need urgent attention.
Legislativa para abordar las disparidades a la atención médica en Nevada.
from the legislative side to attend disparities in Nevada.
Es inaceptable que personas como yo nos enfrentemos a un sistema de salud roto y cargado de barreras financieras.
It's unacceptable that some people like myself have to face a broken health system full of barriers.
La atención médica es un derecho fundamental y es hora de que nuestros legisladores actúen para garantizar que todos los nevadenses tengan acceso a la atención médica que necesitan.
The medical attention funds are definitely needed, and we need from the legislative to make sure that they provide to Nevadans the medical help that is needed.
En resumen, mi testimonio es un llamado a la acción en nombre de todas las personas que luchan por acceder a la atención médica.
In summary, my testimony here is a call to action in favor to those that are fight to receive medical attention.
En Nevada, en instinto al comité a tomar medidas decisivas para abordar estas disparidades.
In Nevada, and I asked the committee to take action to reduce disparities.
Y garantizar que cada nevadense tenga acceso a la atención médica que merece.
To guarantee that everyone in Nevada has medical attention that they deserve.
Por favor, gobernador Lombardo, en mi persona le pido de su apoyo para que podamos tener Medicaid las personas que no hemos tenido. Yo
Please, Governor Lombardo, personally, myself, I ask for support for people like myself to have attention that we haven't been able to get.
tengo aquí yo 30 años en Estados Unidos solicitando Medicaid y no he tenido respuesta.
I've been here in the United States for 30 years petitioning Medicaid and haven't gotten a response.
Tengo un hijo de 24 años, soy madre soltera.
I have a son that is 24 years old. I'm a single mom.
El cual mi hijo él es el que me cuida y por eso él no ha podido estudiar.
And my son takes care of me, and that's why he hasn't been able to go to school.
Le pido con el corazón en la mano me apoye para ver si puedo obtener Medicaid para que mi hijo pueda seguir sus estudios.
I ask you from the bottom of my heart if I could get Medicaid so my son could continue with his studies.
Muchas gracias.
Thank you so much.
Thank you so much. Is there anyone else that would like to provide public comment at this time? Seeing none, we'll go ahead and close public comment and move on to the next agenda item. Just give me 1 second. We're going to go ahead and move on to agenda item number 3, which is approval of minutes for the meeting on February 16, 2024. Committee members, are there any questions regarding the meeting minutes? Seeing none, at this time, I will go ahead and entertain a motion to approve the minutes of the committee.
So move.
We have a motion from Senator Nguyen. Do I have a second? Second. Seconded from Assemblyman Nguyen. Are there any comments or discussion on the motion before we vote? All those in favor, please say aye.
Aye.
Any opposed? Motion carries. All right, we'll go ahead and move on to our next agenda item, which is agenda item number 4, consideration of regulations proposed or adopted by certain licensing board pursuant to NRS 439B. So I have Mr. Robbins who will go over the regulations, and just as we did before, if there are any regulations that you guys have questions on, we can go ahead and pull them at that site, and then we can ask specific questions to some of the entities. So, Mr. Robbins, please proceed.
Yes, Eric Robbins, LCB Legal. We have 5 regulations for the consideration of the committee today. LCB file RO13-24 of the State Board of Pharmacy, RO22-24 of the Board of Psychological Examiners, R124-21 of the Nevada Physical Therapy Board, R004-24 of the State Board of Health, and R024-24 of the State Board of Oriental Medicine.
Thank you so much, Mr. Robbins. Committee members, are there any regulations that you would like to pull aside for questions or comments? I don't have anyone here in Southern Nevada. Anyone in Northern Nevada? The only one that I have questions, I don't hear anyone in Northern Nevada. The only one that I have questions on is LCB file R12421, the Nevada Physical Therapy Board. I don't know if there's a representative in Carson City or in Nevada or virtually. There you go.
Hello, Chair. My name is Jennifer Nash. I welcome you.
Pleasure to meet you. Sounds great. So I just had one quick question. Let's start off for this regulation. Could you just give us a brief background of like what the intention is and what the board is looking to accomplish?
Sure. Jennifer Nash for the record. I'm sorry. The regulations are to clean up language, make it consistent with current practice, ensure that we are providing free access for veterans. It also provides physical therapist assistance, a pathway to have jobs that do not require supervision once licensed. So several minor changes such as that.
Great, thank you. And the reason why I was asking those questions was I did notice that there were considerations for foreign educated physical therapists. And so I just wanted to, perhaps if you could elaborate about some of the changes there. I know that you referred to a few accreditation boards, both in the United States and out of the country. And so I just wanted to make sure that if I was a physical therapist that was already trained and practicing in another country, this wouldn't add more regulations stopping that. It would be the reverse and would encourage it. Is that correct?
Yes, sir. That is correct.
Great. Thank you so much. Any other comments or questions from committee members? Seeing none, we'll go ahead and close this agenda item. Thank you so much. Next, we'll go ahead and move on to agenda item number 5, which is a presentation on public health needs and priorities to improve public health in Nevada pursuant to Senate Bill 118 and policy considerations to address the challenges and gaps in Nevada's public health infrastructure. So, as I mentioned earlier in our comments, we do have a robust number of presentations and folks working in public health. So to start us off, we're going to start off with Ms. Julia Peak, who is the Deputy Administrator of Community Health Services in DPBH. And then followed by that, we do have a number of representatives from across the state working in public health that they will have their presentation to go over what their gaps and initiatives. But let's start with Ms. Peak. Welcome back to HHS, and please begin when you're ready.
Perfect. Thank you so much, Julia Peak. For the record, I serve as one of the deputy administrators for the Division of Public and Behavioral Health. Apologize for my voice, so I'm getting over pneumonia. And so if I start coughing, I'm just going to go on mute and then cruise through. First of all, thank you, Senator Doniate, for allowing us the opportunity to present each interim. We're just so delighted that we can talk about public health. Very directed presentation this time around, so appreciate your staff for being wonderful and helping us prep and plan for the presentations. I just wanted to highlight real fast our mission, vision, and purpose with a focus on our purpose to make everyone's life healthier, happier, longer, and safer. We've gone through a really intensive process through as we apply for public health accreditation, and some of that is looking really closely at our mission, vision, and purpose and the culture of our organization. So that's really important to us, and we want to preface our slides with that. First slide that we wanted to focus on is talking about our public health workforce. We do have a 21% vacancy rate at the Division of Public and Behavioral Health, but that's an improvement from 26% from about a year ago. So really want to thank our HR staff and all our staff for focusing on recruitment and retention. We also have a lot of successes in this area. For the first time ever, we have funds that can focus on recruitment and retention. It's really a result of the COVID-related funding, including ARPA projects that the interim Finance Committee approved for us. So huge thank you to them for that, and I'll give a few updates here. So one of the successes that we wanted to note is noted there, and I encourage everybody to visit that. nvhealthforce.org is a website that we developed to to talk about what public health workforce looks like and healthcare as well. We had embedded the opportunity to build a website in one of our ARPA projects. And this is going to include highlighting the scholarships that you all approved at the Interim Finance Committee, also helping people navigate the jobs at the Division of Public and Behavioral Health. Our classified system can be a bit cumbersome, and also highlight specific job opportunities. In phase 2 of the development, we're also looking at more interaction for the individual. So if they type in, for example, their education and interests, maybe we can give them some opportunities both for scholarship, but also for jobs if they're ready to enter the workforce. So I think that'll be a really good opportunity, not only for DPBH, but we're expanding it to all DHHS agencies as well as our local partners to highlight public health opportunities and better help navigate for folks. One of the things that we're very thankful for is we also got the Public Health Infrastructure Grant, as did Southern Nevada Health District. They got funded directly. This is a grant to all states and some localities that allows us the opportunity to focus on infrastructure, and we've never really had that capacity. With our federal grants, most of them are categorical. This is one that has some categories, including data modernization, but a large focus on filling the gaps that have been identified by us in Nevada. So we've been able to increase staff in information technology, as well as public health preparedness in our Office of State Epidemiology, just to name a few. This subgrant also requires a portion of the grant to go out to our local health districts, outside of, again, Southern Nevada Health District, because they got funded directly, and also nonprofits, health districts, and counties. Very thankful that this grant allows us the opportunity to continue to fund projects such as our academic health department, which has been very fruitful. Also partnering with the Nevada Association of Counties to continue to fund their public health liaison, who's going to present to you later and is a unicorn. I'll just note on record. Also subgrants to support various projects, including, again, at our health districts, and they'll talk through that. We've also hired some contract staff to help in our fiscal and support for our FIG grant and our pipeline efforts, so very thankful again for that. Our ARPA projects. So those of you on the Interim Finance Committee, this is duplicative, so I will run through these fast. You all allowed us to devote funds for an EPI and biostat pipeline. I think the utility of those positions was very clear during our COVID response and remains just infrastructure at the agency for all public health. You also approved the opportunity to get healthcare and public health workforce scholarships. This includes clinical rotations. It also includes some healthcare workforce pipelines that you maybe don't see scholarships for as often, including doulas, community health workers, lactation consultants, certified medical assistants. So we're in the process, we finished the RFP and in the process of getting all those funds out. All of that will be highlighted for folks on the nvhealthforce.org website. So if anyone in the public is interested in any of those pipelines, I encourage them to go there so that they could figure out how to apply. We also have internal programs to retain staff. Some of the funding that was approved with that ARPA allows skill development for our staff, and we're being thoughtful about who gets that, including certain duration of time already served with the division, 5 years plus the willingness to continue to work. So growing our workforce for those dedicated state employees. Some of the challenges, I'm sure you'll hear this echoed in the presentations to come, is just maintaining this good work after the ARPA and COVID funding ends. And I'll note, if we can't maintain it, good work was done, will be done in the next several years that won't be lost, but it's great to maintain some of those if we're able. We're also funding project-specific staff, including the Nevada Office of Minority Health and Equity, Diversity, Immunizations. Those funds will conclude starting in May, but through around 2027, so we'll be looking to lose a good amount of staff if we don't have a way to retain that funding. Also, recruiting and retaining staff is a huge challenge. We're seeing some improvement, as I mentioned when I started this slide, but always difficulty in that area, so being thoughtful about that. Preventing infectious disease is another area that we were asked to highlight. Our epidemiology and contact tracing, as you all saw from COVID, is a way that we can control infectious disease. There's means in which we get information to those who have tested positive, and then we can quickly mitigate and find those folks and their contacts. One of the challenges historically is that we just don't have a lot of funding in this area. Federal funding is really the backbone of this, and so as federal funding ebbs and flows, boom and bust cycle is what we noted here. That's a real challenge, and even if folks have degrees in epidemiology, that's wonderful, but a lot of it is on the job training, actually talking to individuals. And so when we have that boom and bust cycle, we have to get new staff on, train them, and then often the positions are lost or sunset. Just one quick example for our Office of State Epidemiology, just to provide what the state infrastructure looks like. At the peak of COVID, we almost had 80 staff. We're down to 60 just because the funding is decreasing. If we don't get additional funding in about 2027, when that COVID fund sunset, we'll have about 15 state FTE staff, which again has been what has been in place for really since I started about 18 years ago. And that's challenging when we have a population increase, infectious disease increases just as a result of that population. And if we don't have the staff to focus on that infectious disease response, it's a challenge to stop it. Next, I'll note interoperability. This is an area where we've not had a ton of funding in the past, but so thankful that the federal government and a variety of grants to us have given funding for data infrastructure and modernization. When we started COVID, much of the state's work in epidemiology was done via a fax machine. Unlike the rest of the world that had really upgraded to better technologies, now that the federal government is allowing us to get some data modernization funding, we can really dedicate time and effort to making our systems much more efficient. One of the ones we wanted to highlight is our ability to upgrade our vital record system, hugely important to all Nevadans. We're focusing right now on interoperability with Clark and Washoe County, and we're going to look at the rural county coroner's offices next. We're also looking at integrating our EpiTracks, which is our infectious disease system, into this vital records system with a better interoperability so our teams can see the data much more quickly. Another project that we're working on is the Health Data Lake. A Health Data Lake Cliff Notes version is a repository of data. It's going to help us with a variety of things, but much better opportunity for analytics, utility of the data in more real time. So that's one of the projects that are funded that we're excited to provide updates on going forward. Another thing that we were able to do is get funding to move from a CDC's free system, I'll say the NEDS-based system, NBS, to EpiTracks, and that has allowed us much more ability to customize our data collection systems and also do analysis. We also got funding to increase the opportunity to have electronic data exchange with our laboratories, which again just increases the timeliness of the data so we could follow up more quickly. Senate Bill 118, can't start this slide without saying a huge thank you to this committee who sponsored this bill. Your bipartisan support was the backbone of the success of getting this. So as you recall, $15 million was approved. There was an allocation given to the health districts and the counties. DPPH is not using any of those funds locally. We wanted to just do a per capita allocation to every county. And that's been a really fun and interesting process. NACO's going to talk about it a little bit later in the presentation, so Amy will highlight that. But the variety of projects we're seeing come through is incredible. It just speaks to the diversity within each county. There are some challenges with it because it is just a one-time allocation, and we'll cover this a little bit later as well. But everything from a really specific focus on the seniors in their community to jail-based services and making sure that we're thoughtful about STD screening, immunization, et cetera, in that community, and not missing opportunities to provide a public health services where we're able, regardless of the location. The counties are going to speak more to what they're doing, but I just want to highlight that theirs is based on local needs assessments, areas where we don't have funds, just real gap in the categorical grants. So great work for them there. I do want to highlight again that NACO has been a huge partner for us. They're working on ideas to what sustainability looks like and being a little more thoughtful maybe about how that's allocated. Perhaps not strictly a per capita basis, maybe a funding formula as we do with other federal grants. Also would love some opportunity to have funds at the state for statewide efforts, including like data modernization and other things that are a statewide activity. In the initial bill that was put forward by this committee, there was a 5% allocation, and it just it was removed over the course of the bill. So something like that. Also a carve out for our tribal health partners. I know you had a presentation earlier for this committee. We're working with our tribal health partners to figure out what that looks like, but a specific carve out for them with some sort of funding formula would be a huge win if we are able to find some sustainability. I believe this is my last content slide. Just what was asked to highlight how we look at Healthy People 2030 and how we utilize that. You were presented a couple committee meetings ago about our state health improvement plan. And so Healthy People 2030 is really a benchmark that our federal partners have developed, and that's included in our SHIP. We provided some examples of how we utilize that as our goal, as a benchmark. Also, we have what's called the Network of Care for Public Health and Wellness. You could Google it. We have data by county for a variety of measures, and the benchmark for that is always the Healthy People 2030 goal, where there is one that aligns. We're also embedding Healthy People 2030 in our performance metrics. If there is a benchmark for what we should be striving toward for a certain measure, we'll use that. And then most of our federal partners do have some sort of Healthy People 2030 tie for the categorical fund, so we're reporting on that and tracking that really closely. My contact information if anybody has questions or follow-up, and then our acronyms. Happy to take questions now, or happy to turn it over to my colleagues, whatever the chair prefers.
Thank you. Let's go ahead and pause and take a few questions from committee members. I know that this was just specifically focused on DPBH statewide, so if anyone has any questions, now would be the time. We don't have down here. Anyone in Carson City?
Mr. Chair?
Please proceed.
Thank you. First, thank you. It's always good to hear from you. Your work continues to be excellent, and thank you for that. I have a question on slide number 3, public health workforce. Appreciate what you're doing, the fact that you've decreased your unemployment, the positions. That's always appreciated. I'm wondering about, you talk about the rotations that some of the students have to do, and hopefully you have enough folks that they can rotate with, and some of that education. And one of the things that I've been kind of focusing on is many of these folks, when they get the scholarship to attend these schools and they can get reimbursed afterwards, do you have any programs where they're actually getting a stipend to do these rotations, and so that they're able to do that, not only the students, but your own staff? Because I want to make sure that we can support those who are interested in advancing their degrees and not having to not do it because they can't afford to leave the current job, or they don't have enough money to spend the time in the rural areas and the cost. So do you have any programs like that, like we did with the nursing program, where we were able to do the interns and our nurses and they got paid to go rotate?
Julia Peak, for the record, through you, Chair, to Senator Titus. I'll highlight right now as well, my preceptor, Brandy Bengoa from Lander County, joined me today. She is going to nursing school, so she has been working with me remotely. But huge shout out to the School of Nursing at UNR, who's allowing her from Lander County to complete her degree. We are doing a similar thing with our rotations, I would say, but more scholarships. Some of the proposals that were put forward that were funded focused on like certificate programs. So you could get a certificate in epidemiology that's more remote based. And so we will train them where they're at. We also have some great online programs that will be part of this. So say you want to get your master's in public health with a focus on epidemiology or whatever the case may be. Again, fully online program, potentially some opportunity to get internships then in the community in which you serve. So good work in that. The clinical rotations, I'd have to go back and look unless Mitch remembers off the top of his head, but partnered with the School of Medicine that does have a focus on rules. That's definitely part of their scope. I can provide Dr. Titus, if helpful, a full listing of everything so that you can see where there's a rural focus to help us promote it really. We're in the process of the promotion right now in the subgrant, so if there's opportunity to get the word out locally, we would love the help.
Great, thank you. Because one of the things that I worry about is just driving out to the rural areas. Where are they going to live when they do those rotations, and the cost of doing that they don't necessarily, do they get a stipend to go out there, which is I would be very interested in seeing. And thank you for all of that.
Senator Dunyadi, this is Assemblyman Gray. A quick question.
Please proceed.
I misspeak. Just a real quick question. I noticed you do have, it's on slide 5 with the Health Data Lake project, and I know you've got a data governance requirement in there and whatnot, but question is there any PII that is involved in that? I mean, I'm always leery of data breaches and things like that, and especially when it comes to somebody's health records. I'm just wondering if there's any, personally identifiable information where somebody could gain some information they wouldn't otherwise have.
Julia Peak, for the record, Division of Public and Behavioral Health, through you, Chair. Great question. We do have PII in our data sets, but have a high level of security. I'll note that your LCB is doing an audit, and we'll be looking at these things, our infrastructure for data security, how we're handling it and storing it. So those are things that we take very, very seriously, and then also it's being looked at again by your team.
Thank you.
Any other questions? Assemblywoman Brown-May.
Thank you, Chair. Thank you, Deputy Administrator Peak. It's really great to see you this morning. I appreciate the presentation. I'm curious to know, as we talk about the data that we're gathering that came to us through the new systems that were instituted right throughout the pandemic, we're now tracking things differently. Can you talk a little bit about what you see the long-term success of that data collection is? Have we been able to identify areas that need further attention? What does the future look like?
Julia Peak, for the record. Sorry, I'm losing my voice a little bit now. But I got mostly through it. That's a great question. As we look at what the future looks like, some of our goals are going to be less standalone systems. And that has been a challenge for our division, and I'd say the local health departments as well. When we were using the free CDC-based systems, we didn't have the ability to modify them and add things. So, for example, we'd have to have a new data system if we needed to collect data for healthcare-associated infections that wasn't embedded within that system. So what we're trying to do is less systems that are more complete, so that maybe we have, not 200 applications, I can't tell you if that's correct, but less systems, so that we maintain a single system that has as much data as possible in those systems. Also, that's more timely, and that really speaks to the interoperability piece. In the past, prior to COVID, as I mentioned, much of the work was done via fax, phone call, et cetera. You can imagine the timeliness issues with that. Also, the opportunity for humans to make data entry errors. And so as we modernize that, having a real-time flow of information from the hospitals or labs or vital record system into our infectious disease response is one example that can greatly alleviate the time it takes for staff to understand the scope of the condition and respond appropriately. Also embedding immunization data into our infectious disease response. That helps us to understand quickly if the individual is vaccinated or not, and that helps us just as we prep for our investigations. So less systems, more timely, more complete, and then the ability to modify more quickly should we need to collect an additional variable related to a certain condition. That's all going to be something that we will achieve and are achieving now, but we'll achieve much better with the investments and the efforts now.
Thank you, Ms. Peak. That's really great information. I just have one quick follow-up. Do you feel like we have the right systems in place right now, or is this something that we will have to go to RFP for in the future, right? Are we looking for additional investments in this infrastructure, or do you feel like we're on the path currently?
Another great question, Julia Peak, for the record, through you, Chair. I can't say that we would not have to go to RFP in the future. We are still low budget. And so other larger states maybe have better systems that are more efficient. If we feel that we've outgrown a certain system and that there's opportunity to get a better one, we certainly might go to RFP in the future. We would never do that without a funding stream to support it. In some cases, the federal government may requires part of a grant to develop a better system, and the current system might not have the capacity. And so we might have to go to RFP in the future, but we'd never do it independent of an already identified funding stream and need.
Yeah, thank you so much. And it's my understanding that the federal government, the National Coordinator of HIT, has mentioned that the next stage of data governance is going to focus on public health. And so a lot of this will be, from my understanding, predetermined what federal regulations look like. Senator Tidy has brought up a good question of how we're doing scholarships for advanced degrees, it prompted me the question that, this is more of a comment, it's not a question because I have other questions, but it was a thought that I know that other states have looked at expanding tuition remission programming, not just to university employees, which typically university employees get, but to all public employees. And so I know that's probably out of our scope from our committee, but just as a quick thought. With regards to how we fund public health, so last year during the presentation that we had in HHS and Senate HHS, we looked at that the majority of the funds that both the health districts and the different departments get primarily are essentially 75% from the federal grants that we're getting. So it's from the federal government. There's a short amount of money that the state funds it. And so, Ms. Peak, can you just go over like how is public health funded statewide? I think that would be a good conversation starter just as a baseline.
Julia Peak for the record, Division of Public and Behavioral Health. Great question, Chair. And it does vary. I'll speak state and then I'll allow the locals just with one caveat to speak to theirs. But for the most part, at the Division of Public and Behavioral Health, we're mostly federally funded, categorical with the exception of like the public health infrastructure grant I mentioned earlier. We do generate fee revenue for some of the programs, including the Cancer Registry, our healthcare quality and compliance, environmental health. Those are fee-based funds where we provide support to the community and are reimbursed in some capacity. And then we do have general fund. I mean, the $15 million that not being used by DPBH specifically is a huge increase in what we've seen in the past. We do get some general fund for our programs, including our immunization program. You all have funded cocooning projects in the past, a match for our ship. Also, women's health connection type screening for breast and cervical cancer. So those are our programs that you guys fund with categorical general fund for a specific purpose. But for the most part at DPBH, we are primarily federally funded with those categorical grants.
So then the follow-up question that I would have is on slide 3, you talked about how there is going to be some staff layoffs that are going to happen within the next few years. Do you have an estimate of how much revenue or funding you would need to capture those staff members? Because it's for the first time we've had this infrastructure and now it's disappearing overnight. And so do we have an estimate of how much we're going to be in a downfall from?
Julia Peak for the record, Division of Public and Behavioral Health. Great question. And I don't know that we've prepared it in that way. We're also thinking long-term, which positions do we specifically need? If the position was COVID-specific, doing investigations, then retaining that position, it may not be necessary. So we're trying to be thoughtful and prudent on that. We can provide that. I'm sure we'll provide it during our budget presentations as well when session starts. But I do just want to highlight, and I failed to do it during the presentation, that the governor did put in his 3-year plan dedicated funding for public health services. So interested in seeing what that looks like. But the positions that have found great utility in the agency beyond COVID response, those would be things we'd look at funding in perpetuity if we had the option through general fund or if it's a fee-based program, something like that.
Thank you. And I do want to thank our governor, of course, for including that as part of his strategic plan. The last thing that I have was on when talking about SB 118, which I know we're going to have the health districts present, I think there's always a conversation of like, what does equity look like? And is there a potential of revising how the formula is allocated as like every county gets a baseline, whatever you use that money for the baseline, you can come back to our committee or to IFC to say what you're going to use these funds for, because it's a need for every county, not just those with the greater populations. And then looking at, okay, now once you receive the baseline, here's how much more income you're going to get per the formula that we've adjusted. Is that a conversation that you think is needed? Like what are your ideas of reforming the current formula that we have?
Absolutely. Great question, Julia Peak for the record, and I'm not going to steal the thunder of my presenters to follow me, but that's exactly what we're looking at. We're looking at what funding formulas look like in grants that have been successful. So, for example, just our public health preparedness federal grant, that's an infrastructure based allocation, and then there's some per capita consideration after that. That model's not bad. It allows the smaller counties to have a level of equity in that. You could also specify what that infrastructure funds. You have one position that focuses on public health improvement and accreditation, or whatever the committee deemed appropriate. We are looking at that funding formula and being thoughtful about that. Also speaking with states that already have this investment and like, what mistakes did you make when you allocated the funding? We learned through that effort that it was you need to specifically carve out funding for your tribes. You need to carve out funding for the statewide initiatives versus just a per capita, which, again, hugely thankful for a per capita allocation that this committee supported. But going forward, if we have the opportunity to do it again, it would be a funding formula and then specific carve-outs where other states who have been in our footsteps, I would say, have learned more. And NACO will present on this as well, and much more eloquently, I'm sure.
And last question before we move on to the next presentations. I'm sure you have a lot of friends that work in different states that would do the same level of work. Have other states explored like section waivers through Medicaid, through CMS to couple public health funding with Medicaid reimbursement and try to seek federal matches? Is that something that sounds familiar, or am I just speaking out into the air?
Not speaking out into the air. Julia Peak, for the record. Very thankful for leadership at Medicaid who has outreached to us about potential opportunities to partner in public health in ways we were not privy to before. So I'm excited to see what session brings and what comes forward in that regard. But I'll say they've already partnered a great deal. I mean, we partner with them on the CHIP funding. We also have worked many sessions to get the community health workers, maybe not perfect, but in a reimbursement model. So much of the work that we do is trying to understand what a public health investment could do that maybe eventually could be sustainable with a private payer, Medicaid, and then if private insurance covered it as well. So again, great partnership with the leadership at Medicaid, trying to understand which lines of effort in public health that could happen. Also, I'll just say for sustainability, we're trying to figure out, does it make sense that public health federal grants are an initial investment in the community and then there's some sort of match ongoing to see if we can sustain that with community partners? Because federal funding can be cut, and it's really unfortunate then when we lose entire programs. Easier said than done to find a local match, but things we're talking about to make our infrastructure a little bit more sustainable than relying on grants alone.
Yeah, I think that's important. I think it was good for the first go around of looking to set this fund up, and I think now we're understanding that perhaps there are more disparities in certain small communities that might not have as big of a population. And so I think from our goal as a committee perspective, it should be, how do we empower those counties that might not have the finite resources to also stand up these programs and support them in doing so as a matter of public health. But I appreciate your comments. We'll go ahead and turn it over to our next presentation item, which is representatives from different jurisdictions, and so folks can come forward. I think we have some folks online too. And then go ahead and proceed when you're ready.
Good morning, Chairman Danyate and members of the committee. I'm Kevin Dick, and I'm the District Health Officer for Northern Nevada Public Health. And we're very pleased to be here today. I'm joined by the other local health districts and our local health authority. Immediately to my left is Nikki Aker. She's the administrator of Carson City Health and Human Services. Sitting next to her is Darren Winkleman. He is the administrator of the new Central Nevada Health District. And I believe on Zoom, we have Dr. Cassius Lockett, who is the Director of Disease Surveillance and Control at Southern Nevada Health District. And he is representing Dr. Furman Ligon, District Health Officer for Southern Nevada Health District today. And we've been asked to cover the state of local public health, our priorities, disease investigations and sexually transmitted infections, public health interoperability / data modernization, SB 92 and what's going on with sidewalk food vending, Healthy People 2030 and how we measure our progress, plans for the SB 118 Public Health Improvement Funds, which we will be receiving next year, and then also recommendations that we have for the committee. This is the first time that I've appeared before you, and now representing Northern Nevada Public Health because we changed our name from Washoe County Health District to Northern Nevada Public Health at the end of last August. And we did that because the cities of Reno and Sparks and Washoe County wanted the community to better understand that we're a regional agency governed by the District Board of Health and not a Washoe County department that falls under the direction of the County Board of Commissioners. So it was a heavy lift, but we've accomplished that. As I begin to run through the slides, I'd note I am going to be presenting the bulk of the material this morning, and we've reorganized the slides from a printed version that you may have. So we've pushed the SB 118 slides toward the end, so we'll have each of the health authorities and districts speak about their plans for that SB 118 funding as we get to wrapping up. So as far as the state of the local health districts and authorities, we're currently in a state of uncertainty and concern in regard to our future funding and our public health workforce. We had a massive influx of funds that occurred through COVID-19. We know those funds are going to be going away. We have a one-time shot of funding at this point through SB 118 that we'll be getting in July, and we have up to 2 years to spend that money, but we don't know at this point whether there's going to be other future funding behind that. So we are concerned as we have built some much-needed capacity in public health, and we don't want to fall back into the cycle of neglect and crisis for funding for public health. In the Central Nevada Health District, they are brand new, just began their department in July of 2023, and so funding for them is very important for their continuing growth as they build their district and sustaining the programs and staff that they develop. Our other concern is our public health workforce. And as we've now built some of the necessary workforce capacity with the influx of funding that we had during the pandemic, it's important that we learn the lesson from the pandemic. That is that we need to have adequate staffing and maintain our public health capacity so we're prepared for public health emerging issues and emergencies as they occur. In my health district, we did a capacity assessment of our staffing levels against the foundational public health services and what would be expected for appropriate staffing for a community our size. And we found that we're about 30 positions short just in those foundational public health service areas. A lot of the funding that we received from for the COVID response, as Ms. Peak noted, went toward COVID-19 disease investigation, contact tracing, and the immunizations, but not across the range of areas that we need to address. And we find that our workforce salary and benefit costs are increasing rapidly with inflation, wage growth, increased benefit costs, and so we're kind of stuck in a tough position with those costs going up for us and the uncertainty in our future for funding levels. There was some mention earlier in public comment about the Public Health Workforce Interest and Needs Survey that was conducted in 2021 and the increasing turnover that's occurring in public health staff and plans for people to depart public health. That survey found that over half of our public health workforce has symptoms of PTSD following their response to the pandemic. And speaking of turnovers, I am going to be retiring this spring. So the District Board of Health will be meeting on Thursday to approve a contract agreement for Dr. Chad Kingsley, and he will be joining our health district and taking the reins May 13th, if everything goes according to plan. We have some shared priorities in public health, and one is the disease investigation and contact tracing. While we have been able to bolster our staffing in this area, we are already seeing funding ending and being reduced. We have lost funding for years 4 and 5 of an enhanced sexually transmitted infection investigation grant, and that was due to the negotiations over increasing the debt ceiling. So that was a clawback of those funds that occurred. And we've also experienced a 25% cut in our STI federal funding occurring this year. An area that we have always recognized as important in public health is health equity and the inequities that we see occurring in our population and across different communities. That was starkly magnified for us during the pandemic, and we are all very intentionally working to try to do a better job of recognizing areas we need to focus on for health equity in our communities. We were fortunate to be able to receive some pass-through funding from the state that was a CDC grant, the diversity grant, that allowed us to staff up and build a more robust health equity program. Unfortunately, that funding is ending at the end of May this year. So as oftentimes is the case, you'll get some federal funding and then it runs out. We're fortunate with that workforce grant that Ms. Peak mentioned, we're able to sustain a few of those staff with that other federal funding source, which will also be running out in future years. And since the pandemic, we've been redirecting efforts back to different areas that we just couldn't put much focus on while we were overwhelmed with the response. Access to care is an important issue and priority for each of us. I will talk about sexually transmitted infections in a little more detail here as I move forward, but a very, very important area for us, as is the opioid epidemic that's occurring. For Southern Nevada Health District, and as we go through some of these slides, I think you'll see we share some of the same priorities. They are working on implementing their strategic plan and implementing their community health improvement plan. Their community health improvement plan includes focus areas of access to care, chronic diseases, transportation, and public health funding. They also would like to expand their public health laboratory to make it a biosafety level 3 molecular and microbiology lab that will support counterterrorism or bioterrorism counter response and communicable disease surveillance for them. They include advocacy as one of their priorities for funding, both from the state and federal levels, outreach and education on priority health issues, behavioral health access, and dental health services. And unlike the other health departments, the Southern Nevada Health District is a federally qualified health center. And so they in Clark County are providing primary care services that the others of us do not provide. As far as the priorities for Northern Nevada Public Health, again, implementation of our strategic plan, implementation of our community health improvement plan. Our plan's focus areas are social determinants of health, mental health, preventative health behaviors, as well as access to health care. We also are working to implement our public health, our Public Health Equity Plan, and we're in the second year of that 5-year plan, and I think are making good progress in that area. We're working on construction of a new TB clinic thanks to $10 million of ARPA funding that we were able to receive from the state. So we're very grateful for that. We're developing our informatics capabilities. We have lots of data in public health, but we need to do a better job of analyzing and presenting that data as useful information that can guide our decision making and the decisions that others, people and organizations in our community utilize. So that's a focus area for us. We're an academic health department in partnership with UNR School of Public Health, and so we're working with them to support future workforce development as well as the continued development of our existing workforce. And I'm going to talk about priorities later on that we have for the SB 118 funding, but I do want to touch on STIs, which is one of the areas that we want to focus on with that funding. And, this is a serious concern. That's increase in sexually transmitted infection cases that are occurring across the country and here in Nevada. And so we have seen from, well, first of all, on this slide, the top bar chart is the types of different STI infections that we see in Washoe County in 2022 and 2023. At the bottom, you'll see reported cases of congenital syphilis from 2019 to 2023. During that period, we saw a 30% increase in reported syphilis cases in Washoe County, but we saw a 340% increase in congenital syphilis cases. In 2023, we had 22 congenital syphilis cases compared to the 13 cases that we had in 2022. Those 13 cases were a new record for us, and of course 22 is tragically even significantly more than that. So what we're seeing largely in these cases are polysubstance abuse mothers who are not seeking medical care. Their only point of contact may be in an emergency department. And so we're working with our emergency departments to try to increase testing and also working with our hospital infection control committee. So it's easily treatable, basically antibiotics, penicillin, and but these women are not receiving that care, and it's leading to the fetal demise in many cases, or birth defects and great harm to the babies. We also are seeing an increase over the past few years in HIV cases that are occurring in Washoe County. In 2023, we had 39 cases compared to 27 in 2022. And that was we had a 44% increase in HIV and stage 3 cases from 2022 to 2023. So we're very concerned about those areas. Now, Central Nevada Health District is also engaged in disease investigation, and they have the challenge of great distances and dispersed populations over the area that they serve. That includes Churchill, Mineral, Pershing, and Eureka counties. But they are working to provide more rapid testing and diagnosis through the new Churchill County lab. And they're also focusing and identifying and focusing on high-risk settings that have a greater risk for outbreaks to be occurring as they're building their new programs. So in addition to developing a new rural health lab in conjunction with Churchill County, Central Nevada Health District is also working to develop a community health assessment and a strategic plan. And a lot of their effort right now is meeting with different populations and representatives across their area and better understanding the rural needs and the rural assets that are in place. also on working on their emergency preparedness planning. For Carson City Health and Human Services, and Carson City Health and Human Services serves a quad county area, so including not just city and county of Carson City, but also Douglas, Lyon, and Story counties. They are conducting outreach for communicable disease control. Tuberculosis is a concern for them. The state funding for treatment of TB ended in 2008, and TB cases can be quite complex, and the disease investigation, contact tracing that goes with a TB case can become overwhelming. You've probably seen in the news the situation occurring in Clark County with the TB cases occurring in schools there, and large numbers of individuals that may have been exposed. Vector is also a concern. With climate change, we're seeing longer transmission seasons for mosquito-borne diseases, and we're also seeing the range of different species of mosquitoes expanding, which then can result in new mosquito-borne diseases to our area coming our way. In Carson City, they're also working on a community health improvement plan, and their priority areas are access to basic needs, access to health care for specific populations, substance use prevention, treatment, and recovery. They're developing a strategic plan, and their priority is to work to retain positions beyond 2026. They want to also continue to build their partnerships, had some successes to build on from the pandemic, and they're working on their public health reaccreditation. I think I skipped over that one on my slide. We're doing that also this year. So Ms. Peak, I thought, did a nice presentation on the public health interoperability, data modernization and challenges and recommendations. But one of our weaknesses that was exposed during the pandemic is our data management capability. In Northern Nevada Public Health, we were managing our cases in a huge Excel spreadsheet, which was just very unwieldy, as we had thousands and then tens of thousands and over 100,000 cases. The NBS database that Ms. Peak mentioned was overwhelmed with the number of cases. The state has now migrated to EpiTrax, but we still have siloed systems and duplicate data entry, so more work to do on trying to get the connections between some of the different systems. Ms. Peak talked about using systems that have more capability so that we can do more within one system, but we still do need to establish some of those linkages. The other areas that will help with that are data standardization. We don't always collect the same data, and we sometimes use terminology in a little bit different ways, so we need some attention to that. And then our privacy and security, as Assemblyman Gray questioned about, is important for our efforts here to have good, strong data governance and security systems. And then we also need more training and capacity building just on the technical aspects of how we make all of this work. So those are some of the challenges that we have to overcome to succeed in our data modernization and data sharing. We're trying to work together, but we also have a new distribution formula for the ELC grants, epidemiology and lab capacity, that covers a lot of this type of data. Are now being put out as a competitive grant versus something we had an allocation for before. An additional challenge that is faced in the rurals is the limitations of connectivity in rural and frontier areas, and the differences in people's use of technology that occurs, particularly in areas where you don't have a lot of connectivity. I want to touch on the sidewalk vending bill, SB 92, that was passed last session. And there was, from the news coverage of SB 92, I think it left people with a wrong impression that this had reduced or waived public health requirements for sidewalk vending. And that is not the case. This bill affects counties with a population of 100,000 or more, so Southern Nevada Health District and Northern Nevada Public Health. And in Southern Nevada Health District, their sidewalk vendors must still follow all of their public health regulations. A permit from Southern Nevada Health District is required, and they haven't reduced or waived their sanitary requirements. They don't have any sidewalk vendors that have had permits issued to them, and any of their sidewalk vendors, therefore, are operating without permits down in Southern Nevada, and they're coordinating with their sister agencies to address unpermitted food vending. This is a map that shows the locations of unpermitted food vendors that they've had reports on, so you can see it's fairly widespread in the area down south. At Northern Nevada Public Health, there's a state task force that's been set up under SB 92 under the Secretary of State's office, and there's one seat for a public health department representative on that. And so we fill that seat with Joelle Gutman-Dodson is our person that's participating on that committee, and those discussions with the task force are ongoing. We have worked to create a payment plan for food cart vendors. We're currently working on implementing this plan, but to allow for the permitting costs to be spread over time in smaller increments for the food cart vendors. We are looking to utilize some of our SB 118 funds to see if there are ways that we can reduce barriers to entry that exist for food cart vendors. We also have about, I'm sorry, I skipped over one of my bullets. We always had the ability for people to get food carts permitted in our regulations at Northern Nevada Public Health. So we do have permitted food vendors that are operating, but we have received about 80 complaints regarding sidewalk food vending since January of 2023. We've hosted and participated in bilingual open house sessions with the City of Reno to provide education on licensing and permitting requirements for people in our communities. While the smaller counties are not subject to SB 92, there is some concern that this may result in different types of public health requirements occurring in larger populated areas than others, and that people may presume that those are the same standards everywhere, or may have to adjust how they operate depending on which county they're in. We were asked to touch on Healthy People 2030, and it's a data-driven national set of objectives to improve the health and well-being over the next decade until 2030. It has 359 core measurable objectives. It has research objectives. It has social determinants of health objectives. It has some leading health indicators. Southern Nevada Health District is a Healthy People 2030 champion. They've been recognized for their efforts to present and measure against the 2030 objectives. And they have a progress tracker that's on their website. You have the URL on this slide of healthysouthernnevada.org. And this is a screenshot of their dashboard showing their performance compared to the Healthy People 2030 objectives. In our health district, Central Nevada Health District and Carson City Health and Human Services, We are working in alignment with the overarching goals and direction of Healthy People 2030, which are to attain healthy and thriving lives and well-being free of preventable disease, disability, injury, and premature death, limiting health disparities and achieving health equity, as you see on this slide, creating social, physical, and economic environments that promote attaining a full potential of health and well-being for all, promoting healthy development, healthy behaviors, and well-being across all life stages, and engaging leadership key constituents and public across multiple sectors to take action and design policies that improve health and well-being for all. And in Northern Nevada Public Health, we follow these overarching goals through our work with our community health assessment. The bar chart you see at the top of this slide shows how we ranked different public health areas through that community health assessment, and the four bars that had the highest rankings are the areas that we have as our focus areas for our community health improvement plan. We have a strategic plan in which we capture basically all of our operations across the health districts and programs and initiatives, and we have outcome measures that we have for each of those. So this is at the bottom just an example of the performance management system that we have in place that's many, many, many pages long, where we're really tracking and assessing our progress across all of these. We recently launched a new dashboard in conjunction with Truckee Meadows Tomorrow that's inspired by our community health assessment, and it provides our community with easy access to see how we are doing around these different measures of community health. That is at nevadatomorrow.org, and this is just one example of a screenshot that shows how we're doing compared to Nevada and the nation, and whether we're improving or doing worse in a measure. And with that, I would like to turn it over to Dr. Cassius Lockett to walk you through their plans for use of the SB 118 funding.
Thank you, Kevin, and good morning, Chairman Vignante and members of the committee. I'm Cassius Lockett, Deputy Director, District Health Officer of Operations with the Southern Nevada Health District. And I'm here again, as mentioned, on behalf of Dr. Leanne to share our priorities derived from local health assessments primarily and some executive team collaboration. So diving into this line item by line item real quick here, strengthening the surveillance workforce involves retaining our communicable disease workforce of over 10 positions that were managing chlamydia, gonorrhea, and syphilis, while these positions were actually on the brink of elimination due to a CDC grant Kevin referenced earlier, being reduced actually in the United States by over $400 million last year. We have an urgent need to continue to focus on sexually transmitted diseases due to Nevada's alarming ranks in syphilis, at one point being ranked 5th in the United States, congenital syphilis, at one point being ranked 9th, in chlamydia, at one point being ranked 14th. And as Kevin mentioned earlier, STDs unchecked is not good. It could lead to serious implications like pelvic inflammatory disease, where you can have a whole generation become infertile, and infant death from congenital syphilis. Our laboratory expansion, to token that real quick, will position SNHD to continue to respond to emerging disease threats like Ebola, H1N1, pandemic influenza, and COVID-19. This is important because we anticipate our projected population will increase from currently what it is 2.3 million to about 2.94 million. So by 2035, we anticipate adding an additional 600,000 residents to our population. So the lab expansion will be crucial for managing increased testing demand. That's going to go up to do our investigations properly, track diseases, and we also study infectious diseases, monitoring variants and whatnot during the COVID-19 era, if you all remember. And now we're all dealing with in the background as we sit here today, highly pathogenic avian influenza, moving slowly across dairy farms, affecting a couple of workers. So I'm going to make sure any mutations there don't get out of hand, but you got to study the disease in order to make that conclusion. We also want to enhance access to care in vulnerable and homeless populations. We want to accomplish this by purchasing a mobile van to deliver services at curbside, including, but not limited to, administration of vaccines. We want to do some STD screening and treatment. We also want to hopefully do some nursing assessments. We want to get to doing some wound care, some urgent care, and of course, make appropriate referrals to our federally qualified health center. Kevin mentioned before that we have at SNHD. And or, if they don't want to become, have a primary medical home, at SNHD and our FQHC, then perhaps we will make sure to entertain the preferred provider for that patient. Regarding FQHC Dental Clinic, we have observed on our Healthy Southern Nevada website that was pointed out, our sort of dashboard of Healthy People 2030 indicators. Even though these indicators are green, we have observed some two troubling trends moving in the directions we don't want to see. And that is 2 data points showing rising oral cancer death rates. And those are increasing and declining dental visits, emphasizing the need for additional oral health services. And so the FQHC is looking to expand in our Fremont Center and add a dental clinic. The funding will support infrastructure, equipment, and staffing, ensuring sustainability by generating our revenue. Our opioid intervention program will be used to address a gap in our current interventions that we have in place. One of them is contingency management. And what contingency management is a psychosocial intervention that involves reinforcing abstinence from substances. So you take a urine test, you're clean, you get rewarded for the behavior. So it helps manage behaviors to manage opioid use disorder. Regarding youth vaping prevention in Nevada, nearly 40% of youth, as a reminder, have tried vapor products, which is a gateway to marijuana and tobacco use. To prevent vaping, we will continue to promote CDC best practices through mass outreach campaigns, surveillance, and evaluation. And then to promote health equity, SNHD will launch a comprehensive communication campaign that will target underserved communities for various health initiatives, including but not limited to. We want to do some things with our back to school immunization clinics, flu vaccination clinics, COVID vaccination clinics. We want to do some outreach around measles when needed, and other things. Our safe drinking water program proposal will increase staff time in our environmental health program to educate operators of water systems and assess conditions that may contribute to water contamination. It's important to note out not just our public health lab, but our safe drinking water program. They're publicly invisible, right? You don't even notice that the work is going on in the background. But safe water is vital for Nevada's growth and economic prosperity, we can all say. To just wrap up this slide, we'd like to thank the committee for sponsoring this bill. However, we would like to see this funding stream become permanent. Thank you.
Thank you, Chair, members of the committee. For the record, Darren Winkleman with the Central Nevada Health District. Yeah, and we'd like to echo those thoughts as well. Thank you for bringing SB 118 and allowing us to obtain some of that funding, although a small portion of our funding, but this particular funding stream for us is at a critical time as we begin to develop our infrastructure for the Central Nevada Health District. We have partnered with Churchill County and the city of Fallon to purchase a new building for the district. And so a lot of this funding, or not a lot, most of this 118 will go through to improve our data infrastructure in general in the new building and ensure that we have secure data moving forward. The challenge for us will be how we continue that as we build that infrastructure out. How do we continue to ensure that we can still have the services and maintain those services within the district? It's a unique district. We have, as Kevin mentioned earlier, 5 entities within the district, all with their unique challenges and unique needs. But then how do we build that to ensure the district operates whole and globally together. And so this funding is critical to get started, but also critical if we can find ongoing funding to help maintain what we develop moving forwards. Thank you.
And Mr. Winkleman, just real quickly, how much funding are you receiving from SB 118?
195,000.
And do you have a description of the allocations of what amounts you're doing to each of the projects you mentioned?
For the record, Darren Winkleman, Central Nevada Health District. We do not have, it's not broken out. We're looking at some servers, data backup systems, mostly data integrated systems.
So the committee can assume that most, if not all, these funds will go to data integrations and so forth, or data infrastructure.
Correct.
Okay, thank you.
Good morning. For the record, Nikki Aker, Director of Carson City Health and Human Services. And you've heard it before, but thank you very much for this funding and sponsoring it. It allows us to do some putting back into our community around what is needed within our community. And it's very important since it's that non-categorical funding. What we are doing with the money, it's going to be based on our third community health needs assessment. This third assessment we did, the hospital, Carson Tahoe Health, did sponsor this community health needs assessment, and we had various partners throughout the Quad counties that did participate. So this is our first Quad County health assessment. And as you know, we are very connected here within the counties, and the health issues do not stop at the borders, and it's a regional issue with a lot of our health issues that we're faced. So our funds will be used within 4 priority areas, and Mr. Dick had already covered those: access to basic needs, access to health care for specific populations, mental and emotional health, substance use prevention, treatment, and recovery. And through the assessment, some of those priority areas that came within these categories, and I'm just going to give you an example of a couple within each area. I'm not saying that that's exactly where the funds are going to go, and I'll explain how we're going to go through that process. So it's items such as access to physical and social activities for youth, competency of providers to serve specific populations, including knowledge of LGBTQIA+ needs and increasing Spanish-speaking providers, transportation to medical appointments, crisis care. Currently, a lot of the counties have our mobile outreach safety teams, or our most, and those teams deal a lot when people are in crisis. Programs, activities to reduce social isolation, increase support, and promote mental and emotional health. And we did see throughout our community health needs assessment that social isolation has come to be a real problem since COVID. And what we are seeing in Carson is an increase in suicides among our seniors, which we're thinking can be because of that social isolation. For youth, increased coordination between school systems and community providers and agencies to address prevention and early intervention. So these funds are going to be available to us by August 1st. Right now, where we are in the process, staff will be making suggestions to our Board of Health in June. And then there will be discussions, and we will formalize how the money is exactly going to be spent within these 4 areas so that we are prepared to start putting the money back into the community when the funds are available. And I'll just note here that the money that we're receiving in Carson City, we are using only the Carson City funds at this point. Our counties that we do various services in, they have identified their needs within their community. And again, we are very grateful for this non-categorical funding to touch on areas that we have not been able to.
And Ms. Aker, just to make sure that we're clarifying, what was the amount that you guys are receiving?
Excuse me?
The total amount that you guys are receiving?
It's about $282,000.
Great. And do you happen to know the top of mind allocations that you're doing to each area?
I'm not able to specifically tell you the percentages. That will be all figured out in June at our Board of Health meeting, but we will be touching on each of these different priorities.
Okay. As a follow-up, if you can please submit that to the committee, we'd greatly appreciate it.
Sure.
Thank you.
Again, Kevin Dick for the record. I'd like to talk about our SB 118 priorities for Northern Nevada Public Health, but I want to recognize and commend and thank the Division of Public and Behavioral Health on how they are working with us on our planning for SB 118. This is flexible funding for public health improvement that has been provided for our District Board of Health to decide how to spend based on our local priorities. And so it's kind of out of the box for how the Division of Public and Behavioral Health works with us in allocating these funds through an interlocal agreement. And they've been working to provide us with flexibility in how we can allocate the funds across different priority areas. So I have here a list for you of our priority areas. I do not have the specific dollar amounts on them, nor can I tell you off the top of my head. I can provide that for you. But I believe that these go roughly in rank order by the amount of expenditures, with the largest one being epi and disease investigation capacity, working to maintain capacity that was built during the pandemic response and capacity that we know we need when you look at what's happening globally with the new Mpox clade in Africa, what's happening more locally when we look at avian flu, and what we see happening with measles across the nation with cases increasing. The sexually transmitted infections, another focus area for us, as you heard from Southern Nevada, with the clawback of those federal funds supporting the STI disease investigation. We need to use these funds to fill that gap with that federal funding vanishing for us. Vaping prevention is also a priority to restore a position that we lost this past year when we had vaping prevention funding included in last biennium's budget, but not in this biennium's budget. So the SB 118 gives us the opportunity to use that to address that priority for us. Immunization biologicals, this is purchasing vaccine. We've seen the landscape shift for us with the privatization of the COVID vaccine and with the new RSV vaccine and the antibody for the babies. And so this will provide us funds that we need to purchase upfront those vaccines that we're not allowed to provide our other vaccines to people that have medical coverage. And food cart vending, we do want to use some of the funds to see if we can explore some ways of reducing some of the initial infrastructure costs that food vendors may face with their carts. And then also looking to have some third-party review of our operations in our different direct service divisions to make sure that we are operating efficiently and effectively delivering the programs that we have. And then lastly, we have emerging public health issues, priorities, or emergencies. We just don't know what's going to come along in the future. In some ways, while the pandemic was horrible, it was international, and it prompted a large national response with a lot of influx of federal funds. That's not always going to be the case for what we're facing for public health emergencies. So for instance, if we get measles in our community in Washoe County, the feds are not going to come rushing to the rescue for us with funds for that. So this is, I think, another area where SB 118 and public health improvement funding is so important for us to be able to provide some of that flexibility in how we allocate dollars that are not categorical. And with that, we'll come to our recommendations for you, and that is continued public health improvement funding. It really needs to be sustainable and continuing for it to be useful for us and for us to plan effectively to utilize it. Non-categorical so that we can use it for specific needs and our hands are not tied to continue to focus in areas as we have emergencies occurring somewhere else. We want to find a better mechanism for directly providing this funding to the counties so that Division of Public and Behavioral Health is not in the middle of it and having to have this complicated dance with us and moving forward with it. And we also support base funding in addition to the per capita allocation to support particularly our rural counties with smaller populations to be able to meet just basic infrastructure needs that are required. And then, of course, used to address our local priorities, and that we have accountability. While we don't want to see this rigidly administered like a grant is in many cases, we do need to be accountable, and we're committed to providing our reporting to you on the priorities, how they were determined, how the money that was used, and what was accomplished with that. Now, the need to continue to support and to enhance public health funding is vital. Taking 2021 estimates, which was the most recent we could come up with as far as state investment per capita in public health, and adding the $15 million that is going to be allocated through SB 118, that brings Nevada to $19 per capita for our public health funding. That brings us to 40 out of 46 of the states. There were 4 states that didn't provide information on their state funding for public health: West Virginia, Rhode Island, Delaware, Kansas, and Utah. I'm sorry, it's 5. But these states have not been on my radar as having less funding in the past for studies for public health. So we're well below the median of $37 per capita. $19 per capita is where we're at. So we allocate roughly half of the median for public health funding here. We often hear that we're at the bottom of the lists, all the good lists we find ourselves at the bottom of, and we hear a lot about K through 12 education funding and how they're at the bottom of that list. K through 12, I believe, gets closer to 80% of the average funding for their state funding coming from Nevada. And so we're at 50%, much different, much further off in the funding that we have for public health here in Nevada than that K through 12 comparison. All important needs, but we really need it. And we're really grateful to see the governor place the dedicated funding for public health services in his 3-year plan as a priority. We were very grateful for the action that the legislature took and that this committee championed during the last session. We were pleased to see what a bipartisan effort that was and how it was supported across the aisle. And we would love to be working with you to enhance that and see that happen again this coming session. So, thank you very much.
Thank you so much for that robust presentation. Let's go to questions from committee members. We'll start down here in Southern Nevada and then go to Northern Nevada. Anyone in Southern Nevada that have any questions for any of the health districts or members that are presented? Let's go to Assemblywoman Brown-May.
Thank you, Chair. Thank you for the presentations. I have two questions that I would love to start with that are really about the Southern Nevada Health District. First, on one of the slides, it states that due to increasing federal funds after the pandemic, management is trying to balance its budget to avoid closing public health programs and massive layoffs throughout the organization. I'm wondering if you can qualify what a massive layoff is, and how close are you to actually balancing the budget in order to be able to preserve those positions? On the following slide, it said that the workforce grew from 500 employees in 2019 to 860 in the current fiscal year. How many of those positions are at risk if we don't balance the budget?
Yeah, thank you for the questions. First of all, let me just start off by saying that, as Julian mentioned earlier, that after the pandemic, we are facing reduced categorical revenue sources. You've heard that consistently through the presentation. And that's coupled with marginal increases in general funds. Basically, this has created a structural budget deficit where basically our expenses exceed our revenues in our budget currently. So to avoid layoffs at SNHD, we need to kind of implement strategies to reduce the gaps and create intentional plans to bring expenses definitely in line with our revenues right now. I don't have a crystal ball on what those projections are going to look like in the future. However, some of the things that we're working on right now to avoid layoffs without giving specific positions at this point in time, we are trying to basically prioritize internal vacancies when possible right now. We're shifting positions to different funding streams because we do have a massive amount of COVID funding that's going to be ending in December this year. We've implemented through our budgeting process, zero-based budgeting to try and, reduce costs and supplies and things of that nature. We've reduced travel from our general fund by about 80%. And basically our overall budget, which is currently for fiscal year 25, about $171 million, is down from $191 million, primarily due to COVID-19 reductions. And so what I can tell you right now is that, yes, SNHD does have approximately 866 positions right now. And if we apply benchmark estimates, we actually almost need to double the workforce. So right now, we're trying to do everything we can, as I just described, to hold on and prevent reductions. But I don't have a crystal ball in terms of what that's going to look like because it's complex and funding streams are staggered across different fiscal years. And we're in the midst of trying to balance all of these positions, including funding that ended
Dr. Lockett, when are you?
And also funding that's going to end December of 2020, December 31st, 2024.
So thank you so much for that long explanation. I still didn't hear. When are you planning to have an answer as to when when you will have a response of how many positions are going to be cut and when the budget is going to be balanced? When is there a time frame when we can expect those answers?
Yeah. Our budget is balanced right now. We just presented our budget. That budget has been approved by our board, our fiscal year 25. And right now we're trying to keep as many positions as possible. If you would like, I can.
What is the time frame? Excuse me. And when is the time frame that you will have by the time you know how many positions you're going to cut? When should we expect that answer from you?
Yeah, right now it's going to be two waves for consideration. The first wave will probably be before the end of June 30th. And then the second wave will be sometime in December of 2024. So right now, all of that information is in flux. I can't give you an answer because it's in flux. And we're trying to place people in vacant positions, et cetera. And so I don't have an exact number for you, but once we get that number, we can perhaps circle back around to Dr. again and get you that information.
Sounds good. Completely understand. I do ask the health district officers that are answering questions today to not be long-winded and try to be direct as possible, simply because we do have a lot of questions from the committee members. Any other questions down here in Southern Nevada? Let's go to Dr. Ornlicker.
Thank you, Chair. Thank you for all of you for your presentations. I have a question on the projected proposals for Southern Nevada. And all important areas, and looking at a couple of them, the laboratory expansion and the dental clinic, they strike me as projects that might be attractive to philanthropic givers. Is that something how much do you explore that, and is that something that might help out in some of these areas?
Yeah, I agree with you. We haven't explored that fully, but that's always an option. And so thank you for that comment. We can definitely circle around and see if we can take advantage of those types of resources in the community.
Thank you.
Let's go to Senator Nguyen.
And Chair, I have quite a few questions. Is it possible?
Let's do two, and then we'll move on.
Okay.
And then we'll come back. We'll have different rounds.
Let's see. Where do I start? I think both Northern Nevada and Southern Nevada, so I'm not sure, probably directed to both of you, are representatives from both of those groups. You had mentioned tuberculosis and the uprise in that. What are we doing to address this? I guess I'll start in Clark County because I'm more familiar with that. What's going on to address the TB outbreak in Clark County? And is this addressed in the plan?
Yeah, so that's a great question. I think right now our current strategy is to work with, as you already know, first of all, let me just say without being too long-winded, that tuberculosis has increased in the United States, and in some places more than 15%. We've also have observed an increase in TB cases. One of the things we can do, and we're working with our state partners on, is trying to find a way to change regulations so that the number of, let's say, workers in schools, volunteers that are in schools, teachers in schools can be screened, not tested, but screened for tuberculosis initially upon hire, which we're not doing now. And then also offer up periodic screening to those same three groups every 4 or 5 years to kind of close some of these gaps so we can prevent. If we can get those people screened and we can get them tested, and we can prevent latent tuberculosis infections in the community.
And, I don't pretend to be an expert, but obviously it seems like this is easily spread and could be contained if we're looking at our schools and our courts and our prisons in areas where, it leads to easier transmission, I guess, and things. So what kind of efforts are you making in conjunction with, for example, the Clark County School District to make sure that all of their new hires or teachers are tested and or screened?
Yeah, right now it's voluntary. The law does not require in this state any kind of legal requirements for screening. So that's one of our challenges, and that's why we're collaborating with our state partners to change the regulations to make it mandatory for, again, those teachers, those workers and volunteers at Clark County School District. And that collaboration has to take place between the educations at the state level and our public and behavioral health folks to get that language smoothed out and approved so we can have those regulations in place.
And as far as some of these funds that are coming in, is there any allocation of, with the SB 118 funds that are going specifically towards the TB? I guess growing.
We don't have an allocation with our TB to increase our TB workforce at this point for our SB 118 funds. But again, non-discretionary funds in the future. if they do become, an annual allocation, those flexible funds could be used in such fashion.
Is there resistance from the school district in doing this kind of testing, or are they open to it, or are they just not open to it because it's not mandated?
Well, exactly. They are open to it. It's just not mandated. So we do have a voluntary screening program for new teachers in place. Again, it's voluntary. We have a web-based form where they could be screened in, and we find out if that screen is positive, so then they could be tested for tuberculosis. But right now, again, it's voluntary, and our state partners are, I think, moving at a pretty rapid pace to try and get this language changed into the regulations to make it mandated like it is in some states like California, not just for school districts, but for employment purposes.
Thank you.
Thank you so much. Let's go to Assemblyman Nguyen.
Thank you, Chair. I just want to make sure we cover the staffing component. I have not heard a lot in the slices about the recruitment retention if we going to face a crisis in terms of increase of outbreaks. I heard we have in the northern part of our state the HIV cases increase, and then down here in the south I heard of TB, and of course a public testimony earlier saying that we have one case manager in Southern Nevada Health District. Is that kind of counterintuitive in terms of ensuring that we are addressing some of these urgency right away? So if you all could help me with that, that'd be awesome.
Yeah, great question again. And to respond to that specific case manager, in our tuberculosis clinic, we actually have a vacant position because someone retired, and we're in the midst of filling that second case manager currently. So, and adding a community health worker position that needs to be filled in our chest clinic as well. So our tuberculosis clinic, excuse me. So we're doing that. But as Julia mentioned earlier, we also have the public health infrastructure grant, which is a 5-year grant on year 2 right now. And we've used that to retain over 40 positions. Primarily, those positions are in disease surveillance and control, monitoring the infectious diseases that you just mentioned.
Quick follow-up, Chair. So thank you for that. And my next concern is that yes, retirement and changes in turnover happens. What is the health district doing in terms of your ongoing recruitment plans and retention plans? Because obviously, turnover happens in every industry. And do we spend any attention into? Obviously, you knew the retirement was happening and you still have that vacancy. So are there strategies that the senior team are doing ensuring that you can respond to this correctly? Because I'm sure that you knew about the retirement. So I want to see if we have strategies in place so that we can continue to serve our public without any types of, pause due to some of these changes.
Yeah, so recruiting for certain positions is always a challenge, especially clinical positions. We've been pretty fortunate to be able to attract and retain qualified people here at SNHD. And so our HR partners are actually using part of our public health improvement infrastructure grant to work on recruitment tools, provide incentives for onboarding people, give them bonuses and other things that come out of that grant. And then we have ways where we're trying to retain people post-COVID, reduce stress and anxiety to retain people. One product is called Credible Mind. It's a public health, behavioral health system that we are planning to launch, and that will reduce anxiety amongst employees, etc. We're also working on trying to incentivize and reward employees through that grant. And we just actually spent money for our Public Health Week this week on a variety of different events for our employees, including hosting them breakfast. But yes, we are cognizant and aware, and I would say that our retention rate is around 10% at this point, which is in alignment with industry standards.
Well, Dr. Lockett, thank you for your hard work in terms of ensuring that we cover all these bases. I'd really like to see, and hopefully the committee also could see the people plans, right? Because it's really important. We cannot get this work done without our workforce. So if you could give us, I mean, I saw your one slide on the budget, didn't really mention anything about, people and the plans for the workforce. So if not the answer, if we can't get the answer today, I would like to see the answer very soon on really these funding when it comes to expanding our workforce, because if, God forbid, we have a bigger outbreak, we just need to be prepared, and meeting the 10% that you said is critical, but I think we should work on exceeding these metrics and not just meeting the standards. Thank you.
Thank you,
Yeah, no,
Assemblyman.
that's great advice. Thank you.
Let's go to Assemblyman Hibbets, and then we'll go to Northern Nevada.
Thank you, Chair. Doctor, how many active cases of TB are in Southern Nevada right now?
I don't have the number offhand. However, last year we went from 54 to around 76 cases, comparing 22 to 23. So that is a significant bump up, and we are having internal meetings to address active TB cases moving forward.
I'd like to ask that you get the number to the committee. Thank you.
And let me
Thank you.
be just, you want 2024 active TB cases. I just gave you 2023.
I'd like to know how many there are right now.
Got it.
Thank you, Dr. Lockett. If you can, I would assume that you're probably in the Southern Nevada Health District building, or if you have other folks that you can message while we ask other questions, maybe you can get that response while we're still in the presentation. That would be helpful. Let's go to Senator Titus.
Thank you, Mr. Chair, and thank you all for your presentations. I have a comment and then two quick questions, if I might, Mr. Chair. First comment. Many of you know and have heard me say that I'm an old doc, and I really am an old doc. And I started practice in rural Nevada in 1984. My TB skin test rapidly switched to positive within a year. So I went through the treatment process way back in 1985 and have to tell you that I survived it. No worries there. But it is common in rural areas to be exposed to tuberculosis. This is nothing new to Nevada, from our tribal nations to the rapid visitors that we have. And then at the time when I started practice, it was some of the from the Vietnam War Vietnamese that had moved. And so we see this ebb and flow and tuberculosis. So hopefully that gets quickly handled. The only other comment I would make about that is, fortunately for me, it was a single drug treatment. It was still sensitive. The challenges that we face today now is the resistance, and so now they're having to take 4 to 5 medications. So there is a bigger challenge. So that's just a comment. Two questions. First, the name change for the Washoe County Health District sent up my little antennas concerning, do we have to go back now in NRS and change wherever it says in NRS Washoe County Health Department that you've changed your name? And maybe staff can, or legal can answer that.
Eric Robbins, LCB Legal, for the record. I'm going to have to look up to see if that term actually appears in NRS, because I'm not entirely sure that
I think it labels different health districts in NRS, and Washoe County, I think, is spelled out, but I'm not sure. And so, I hate to see us have to do one of our bills to change and catch up with what Washoe County did. So we need some clarification, Eric.
So, the way it's normally done in NRS, it's done by, it doesn't actually spell them out. It does by population caps. So I don't think there would need to be a change there.
All right. Well, we'll confirm that after you have a chance to look at that. I know I threw that out there kind of randomly, but I do have another question for Washoe, and thank you for bringing up the increase and mentioning the syphilis rates. We had 2 bills last session that hopefully dealt with some of that. It was AB 192 and SB 211. Both of them involved the testing, and I'm wondering. So the article that came out that I read was about the increase in the congenital syphilises, the numbers, and you stated that. What was there, because we increased money spent and increased access, at least somewhat, to the testing itself, was there a significant number, did we move the needle all in the number of tests that we found and treated? Was there any success in that at all?
That's Kevin Dick for the record, through the chair, to Senator Titus. Excellent question. I would need to actually go back because I think you're saying, are we catching more cases because we're testing more? Unfortunately, I'm aware of cases that we have in those numbers I was reporting to you that tests were not done, and when they could have been, and treatment provided. So I would have to dig into some stats to be able to provide that information for you.
Thank you, because I would really like to see that, because a number is just a number, and yes, we have an increase in numbers nationwide. However, our state did try to do some work, and so I want to know, what the increase did we find in testing, increased number that we caught and we treated. It's always easy to throw out a bad number, but I'd like to see some good numbers.
Yeah, and unfortunately, I think that most of these cases that are congenital syphilis cases they're positive tests that are occurring in the babies.
At the time of delivery, I understand that. Again, I've delivered babies, I understand you have to test all of those, but I want to know how many cases of syphilis did we pick up that otherwise we would not have, and we were able to treat them pre-delivery. So thank you for that. And that was my last question, Mr. Chair. Thank you.
Mr. Chairman, if I might.
Thank you so much.
Mr. Chairman,
Yes.
This is Kevin Dick. If I might, I did phone a friend on our SB 118 budget items, and I can give you those figures if you would like. I backed up to our SB 118 slide. So for the epi and disease investigation capacity, just over $1 million for that. And I think that also goes to Assemblyman Wynn's question about what we're doing to try to work to have the capacity we need if another outbreak occurs. And so this is trying to retain some of the staff that we have that have developed their expertise and experience through the pandemic response with the ramp up that we did there. We have about $250,000 that is for our sexually transmitted infections, again, disease investigation staff that are focusing in this area. We have about $400,000 that is for our vaping prevention program. So I was not correct. They did not go in descending order completely, but the large ones were at the top. Then we have the immunization biologicals, the vaccine budget at $110,000. $100,000 for the food cart vending initiative. I don't think I mentioned the drone training, but we have, we're working to increase our capabilities for mosquito abatement to prevent the mosquito-borne diseases, and so that's $14,000 for us to be able to utilize a drone that we've purchased, and then our divisional assessments budgeted at, sorry, get my glasses here, at $130,000. So currently no money budgeted for the emergencies, but the ability to move dollars between those different budget categories if we do have an emergency. And we have a total of $2.4 million that we're getting through SB 118. And the direction I have from my Board of Health is to work to spend that money over 2 years rather than ramping up sharply with all of it and then potentially not having that money in the future. Thank you.
Thank you so much, sir. Assemblyman Gray, do you have any questions before we come back to Southern Nevada?
No, sir, thank you.
Thank you so much. Well, that's actually, Mr. Dick, thank you so much. I actually think that's a good segue because I was going to ask you guys more on SB 92. Perhaps let's start with Dr. Lockett. I want to hear from Southern Nevada first. What is the strategy to helping out with the outbreak, or I guess the prevalence of food vending in Southern Nevada? Let's start with that basic first question.
Yeah, let me turn it over to Christopher Saxton, our environmental health Director at Southern Nevada Health District, inform that question.
Sure. Chris Saxton, Director of Environmental Health at Southern Nevada Health District. And I think the question was, what are we doing about the outbreak of unpermitted food vendors? With that, it's basically working with our sister agencies here, whether it's basically code enforcement, the police, to identify those areas where we're getting the most complaints, and then trying to have a route with inspectors going by there with those different agencies to try to address the issue.
Great, thank you. And, during the presentation, it was alluded to that perhaps the pathway that the health districts needed to take after the passage of SB 92 was that they needed to stratify the public health risk, because not every vendor can be treated equally. And so where are you guys in terms of promulgating regulations and meeting with the community to update and make sure that the sanitary requirements are assessed to the public health risk and that you're meeting the vendors based on their circumstances, as we heard during public comment today?
Sure, good question. Right now, basically we can permit any of these vendors under our open air vendor regulation right now. Of course, we can offer waivers if they're lower risk for certain items on their cart, so it's a case-by-case basis. With community education, we've been working with the county and the other cities in our jurisdiction on town halls to try to educate along with those groups of what the requirements are and what they need to do. We also worked to have their fees when they need to come in and get their permit. We know that that could be a hardship, and as part of SB 92, we needed to offer them a payment plan. So we did that over 3 months, where they could come in, pay a small portion, get their permit, start operating and make some money, and then pay off the rest of their permit costs.
Thank you. And is the health district, since the bill passage, is the health district still confiscating items on a daily basis for these food vendors?
Well, yes, of course, with the complaints and everything going on, and the feedback we got is they're the task force, and it's also being discussed there, which we're heavily involved and interested in the discussions there of what we might be able to implement and what might help the vendors, but also ensure the public health for our community.
And walk me through that process. If I am a vendor that gets stopped by the health district, what do you provide me at that point in time, since the bill has been passed?
Sure. So we have an education material that's in English and Spanish, basically directing them how they can get a permit, the numbers to call to ask if they need any kind of discussion of what they need to get that permit, because that's what we want, is to try to ensure that maybe they don't know what the rules and the laws are, and how can we help them if they are generally interested in getting a permit.
And, one of the things that was very frustrating when I went with the health district was that I was the one that was translating on behalf of your workers. So have you guys made any segue with recruiting workers that actually speak different languages when talking to these vendors?
Yes, so that's always something when we look at applications for our new inspectors. It's something definitely we highlight. Are they able to speak a different language? And of course, we prioritize those inspectors for those programs where they may run into that population where we need that language. Of course, we do have lines on our phones, so translators available if it becomes an issue. So even if they are not able to speak in that language, they can have somebody on the phone to help translate.
Thank you. And then I think the last thing on SB 92 was that, from my understanding, after the task force creates its regulations, and the task force I'm referring to the task force on safe sidewalk vending, then the health district will begin to develop or identify what they can improve, because right now you're forcing everyone to go through open air vending, which doesn't make sense, as was alluded to, because not everyone has the infrastructure or the funds to provide, say, a dual sink, et cetera. So how long is that regulation process going to take from you all?
Well, yes. So if the task force does deem some regulations necessary, we'll take a look at that and see if we need to adopt our own regulations, since SB 92 gives us till the end of 2025. So it's important to see what comes out of that and what's needed there.
So it's fair to say that the health district does not have a current timeline right now, because you're pretty much just sitting on your hands, essentially waiting for the task force to do their work.
Yes, we're interested to see what the PET first comes out. And then that'll help direct what some of the recommendations are for us to consider for new regulations. And as you know, the regulations are something quick we can turn out. We have to do a business impact statement, community workshops, so it will take some time.
So why haven't you done that yet then? It begs the question.
I think it takes a lot of time to do that. And so far, we've had 0 people so far shown any interest in getting the permit. So it's kind of the cost benefit ratio of staff's time, and seeing how we have it right now, we can permit these unpermitted food vendors if they so wish, in the spirit of what SB 92 requires.
Thank you. I would encourage you all as public health to meet people where they're at, and I would presume that if you did that work, you would actually find that there's plenty of vendors that would love to be licensed. They just don't have the ability to do so yet. But that also begs the question, I think the health district spent a lot of time fear-mongering on the news, talking to folks on why they shouldn't purchase from vending, but I didn't see anything regarding food vending on the Southern Nevada Health District's project proposals. So why, if this is such a big public health concern, why haven't you allocated any funding to helping those vendors be adequately licensed and meet the requirements as you set forth?
Sure, it's a good question. It's the leadership of SNHD got together, and how would we really look at this funding? How should it be dispensed? And what was decided is we should look at our community health assessments. What is the community and everything showing us to be the biggest issues in our community? And those were the items that got the funding.
Thank you. Dr. Lockett, can you walk me through the background as to why the Southern Nevada Health District came up with these proposals and who was a part of the decision-making process?
Yeah, no, thank you, Senator Donate. That's a good question. Our entire executive leadership team, which represents all of our divisions in administration, and obviously Dr. Fermin Ligan, our health officer, we're all involved in those conversations. Some of this information can be found in terms of in our 2021 community health assessment, which is published online. And also there were some other areas that had their own assessments. For example, we're in the midst of completing our opioid assessment and plan, which is a requirement for our overdose to action report. And without going into too much detail in terms of our lab, I just want to say to be a biosafety level 3 lab, you have to be part of what they call a selected agent program, which is a CDC program. That program actually comes out and inspects us annually, and then they do on-site assessments. And some of those on-site assessments directed our attention to the need to expand our lab, to absorb and to get additional space for not only testing to do whole genome sequencing, advanced molecular detection, but also for additional space for reagents and equipment, training and refrigeration. So some of these assessments are in that space as well.
Thank you. I didn't hear anything in the response that you included lower level frontline staff. Is that correct from my assessment? Bless you.
That would be correct. That's correct.
And why was that?
Well, that's a great question. I think right now our executive team had a sense of our priorities, and basically, to be honest with you, some of those priorities are to address some of the concerns from our staff that swell up to our attention. But I'll say in terms of involving direct line staff on the executive team to make those decisions, that was not done, correct?
Great, thank you. I think the reason why I was asking all these questions is probably, as folks in the public may understand, is there's a little bit of frustration with how the health district has been doing a lot of their efforts, whether it's with SB 92 or with the proposal that we have in front of us. I think it's very saddening that a lot of, and this is just my personal interpretation, a lot of what you have right now on your project proposal to me resembles initiatives guided towards your FQHC, but not towards public health. If there is like a disillusionment of your purpose as a health district is to do public health work. If you wanted to do a FQHC work, then that's a different type of mission, right? Because in that type of mindset, what you do is when you have folks come into your facility, you try to, I don't know, ask them for their health insurance and bill as much as you can versus just providing actual the services that you were intended to deliver as a health district. I think it's very saddening that you don't have a lot of public feedback regarding the allocations that you have, especially because we work so hard to give it to you. And, in some of the conversations I've had with your own staff, your laboratory assistants don't even believe that this funding should even go towards the clinical laboratory. They don't see it as necessary. There are other concerns, security concerns that your folks that work for the health district feel could be important in terms of enhancements to reduce the turnover that we spent so much time talking about this morning. And I don't see that reflected either. With SB 92, right? We've spent the last year, the health district, going to different news agencies talking about the prevalence of food vending and the foodborne illness that can exist, and yet you still have not developed a proposal in this budget guided towards doing a campaign to help educate and provide actual resources to these vendors. Same thing with the TB outbreak. There could be a very allocated resources right now, finite resources that could help the school district ensure that their staff are being able to be detected for a TB illness, especially as we mentioned, how contagious it can be, and it's still not reflected. And so all that to say, I think you need to go back and redo this budget and present it again next month, because it seems to me that you didn't do your homework yet. So I'm going to go ahead and let other committee members ask any questions, but that was pretty much from me. Assemblywoman Brown-May.
Thank you, Chair. I do have one follow-up with regard to the Southern Nevada Health District's project proposal for SB 118 funding. It's listed here under the opioid epidemic and smoking that we have an opioid and intervention program, but it's my understanding that we have separate opioid dollars that have come into the state. I'm curious to know why we're not utilizing those instead of this funding.
Yeah, so that funding, which is overdose to action, does not, yes, you're correct, we did not budget for contingency management and didn't realize that was a gap until after our assessment. And so it's something that we wanted to allocate because it's a gap to strengthen our opioid response strategy.
Thank you, Dr. Lockett. I appreciate that. I'm curious to know if there's a way for us to go back to the state dollars in order to fund that opioid intervention program, in that we do have those state monies available. That then frees up an additional $247,000 for you to be able to focus on other programs. I think while we have access, it's really important that we continue to focus on the opioid intervention programs and epidemic in general, but we utilize those dollars to help us do that.
We certainly have had conversations with NACO to make ourselves, put ourselves in a position to be able to apply for the RFP that's going to be launched in May or June, so that we can apply for those state opioid settlement dollars. And so we're in the midst of taking our draft assessment and plan to make sure we're eligible to apply.
Thank you. I think we have one more question from Senator Nguyen, and then I have a few questions for Kevin after that.
I'm going to shift topics. I had some questions, but our chair has covered most of those with regards to some of the issues and concerns I had. When I'm looking at some of the priority pieces and the funding that the Southern Nevada Health District is using with those SB 118 funds, I see that there is a $1.6 million allocation towards developing a dental clinic. Can you talk about what exactly that is being utilized for? Is that construction? Is that strategic planning? What is that? What does that entail?
Yes, you're correct. It's going to be for light construction over at our Fremont location for, I believe, 3 to 4 dental chair seats, and then some startup costs for some positions outside of the instruments and dental equipment that's going to be required. We're talking about a couple of dental hygienists to start us up, a dentist salary over 6 months. But correct, light construction.
And so when do you anticipate that would be up and running, and how many people would be able to utilize that? Do you have that information on, I guess, what the ROI is on that? Like, do you have a more detailed version of what those costs are and what the long-term plan is to continue that?
Sure, we have a
Funding?
more detailed plan. I can surely circle back around after this meeting and see if I can put the details in your hands.
I'm just curious. I know I've been working with some outside nonprofit organizations that provide mobile dental care, and their costs, are significantly lower than this. So I'm curious on what the long-term strategic plan is for that dental clinic and how many people and how many constituents it would serve, what the priority is for those services, what kind of referral network there is for services that are outside of the scope of what a 3-bed or a 3-chair dental clinic would be able to provide. So I'm just really curious about that. So if you could get that information to us, I'd be really interested in that.
Will do.
Okay, at this time, I thank the presenters. I do have a few questions for Mr. Dick. So Kevin, you mentioned that you are retiring. Is that correct, sir?
That is correct, Senator Donyate.
And if I may ask you, how long have you worked in the health district for?
I started working for, at that point, the Washoe County Health District back in 2010, and then I was appointed the health officer in 2013, April of 2013, so it's 11 years that I've been serving as the district health officer, which I think is well beyond the national average. But it's been an honor for me and a privilege, and just a very important part of my life that I'm grateful for.
And if you could, so reflecting on your years of service, what would be one piece of advice that you can give legislators regarding public health in the state of Nevada?
Don't ignore it. I think that's the biggest concern we all have, and we've been ignored in the past. And when you don't pay attention to public health and you don't maintain your capacity, it's going to come back and bite you, and that's what happened.
No, I greatly appreciate that. One of the most beautiful things that we can do as legislators is oftentimes we recognize individuals for their work. And I think in public health is very difficult. We spent this morning talking about the lack of funding, the lack of infrastructure, and oftentimes for our public health workers, including our leaders, it's difficult because we're tied against a system where we don't always have the resources, but we work behind the scenes, right? Until there's a crisis or a pandemic, as we noted, and we often have to rise to the occasion of stress and disaster, and hopefully we do it right. And so I do want to express our gratitude from the committee, but I think Dr. Titus has a few comments as well.
Mr. Dick, we have worked together a long, long time, and I am very honored to be able to present you with a proclamation from this entire committee. So with that, you will just bear with me. I'm going to come down there with my peer here, Assemblyman Gray.
Thank you very much.
So we'll go ahead and take a quick recess so that they can take their photos. For folks in the audience, we are going to take our lunch break right now, and obviously for folks that are interested in the eclipse, and so we'll be back around 12:20. So. Good afternoon. Welcome back, everyone. We hope everyone had
He's getting started,
session.
everybody.
Thank you, Dr. Titus. We'll go ahead and proceed with our few agenda items. So to wrap up so we have a few agenda items that we have documented for the rest of the day. I did want to make one comment on the public health presentations. As you may have noticed, NACO did submit a presentation, and they were going to present on the continual funds of SB 118 for the next legislative session. We made the decision to table that presentation item to another date later on during the interim. It seems that there are a lot of grave concerns with the allocations that have been made by some of the health districts, and so we're going to let them do a bit of their homework before they come back, and then hopefully by the time NACO also presents, we can have an understanding of what language needs to be submitted to do the continual funding before it comes back to the legislature. The agenda items that I have in order are agenda item 6, which is an overview of Nevada's immunization rates and public health outreach efforts concerning vaccination. So that will be the first agenda item if folks can come forward to start setting up. Followed by agenda item number 9, a presentation on the state of Washington's expansion of healthcare coverage for all residents pursuant to this innovation waiver. Then we have agenda item 7, which is a presentation on goals and objectives set forth in chronic disease prevention and health promotion by DPBH. And then our final presentation item will be agenda item number 8, which is an overview of efforts and policy considerations to reduce food insecurity. And then our last agenda item, as always, will be to review the policy recommendations that have been submitted to the committee. So once again, that would be 6, 9, 7, 8, and then 10. So let's go ahead and proceed with an overview of Nevada's immunization rates. For this, we have a few folks that are ready to present, so please begin when you are ready.
Good afternoon. Vicki Ives, for the record, Bureau Chief of Child, Family, and Community Wellness with the Division of Public and Behavioral Health, joined by my colleagues Christy Ziganes and Julia Peak. Thank you for the opportunity to discuss immunizations and vaccine-preventable diseases today. I'll turn it over to Ms. Ziganes.
Thank you. My name is Christy Ziganes. I'm the Immunization Program Manager with the Division of Behavioral and Public Health, and I'm very pleased to be here and honored to present this information today. As Julia went over our mission, vision, and purpose, so we'll just dive right into the meat. So starting with school exemptions in Nevada, this goes looking at year over year. This is the breakdown of school type for exemptions. In school year 20 to 21, public and charter schools in Nevada had a religious exemption percentage of 3.5% and private schools at 5.4%. And then subsequently, medical exemptions have remained relatively the same. Religious exemptions have increased. Coming up to the 22-23 school year, private schools are 8.2% for religious, and public and charter schools are at 4.9. How that compares nationally, according to CDC's School Vax, is that any exemption rate nationally is about 3%, and in Nevada comparatively, we're about 5.6%. What this slide breaks down is showing the different school types. So as we can see, the private schools tend to have a higher religious exemption rate. So let's dive into the successes of the program. The Nevada State Immunization Program is coming out of the pandemic, as everybody else is. So what we did see as a success from this pandemic is strengthen and creation of new partnerships across the state. And we can't do what we do without our partners, so it speaks volumes to that. Recently, we've published the Vaccine Landscape Report, which takes a deep dive into the data of how the pandemic has impacted the state A couple addendums are in the works for looking at the 7 series and adult immunization rates to come. Another success is that we have electronic connectivity between Nevada WebIZ, which is our immunization information system. We have connected with Arkansas, Connecticut, Delaware, Kansas, Kentucky, Oklahoma, City of Philadelphia, New Mexico, Utah, Oregon, and the VA in Nevada. And what that means is if an individual receives a vaccine in one of these states and has that immunization input into that state system, it will electronically transfer to ours. We have also improved the public portal, which is an access point for parents and individuals to access their own official immunization record, and that can now be viewed in Spanish. Another success is our long-term care facility All Vaccines Access program, and that's a partnership between our state program, the local health authorities, pharmacy partners, and other healthcare stakeholders to make sure that individuals within those facilities have access to all recommended vaccines. And we're coming off of the tail end of the COVID, but we're still trying to ensure that access is available at these facilities for not just the residents, but the staff as well. In 2022, our program was audited by Hyde Bailey, and of the 16 state programs audited, ours was the only one that had no findings. So that speaks volumes to the work that the staff does. And then policies that have allowed for expanded access to vaccines that have recently come to fruition are AB 147, which allows the oral health field, dentists, hygienists, and therapists to administer vaccines. So creating an additional access point for individuals that might not have access to other sources. And then SB 172 allows for minors to consent to healthcare services for the prevention of STIs, sexually transmitted infections, and this includes receipt of the HPV vaccine. Moving on to challenges, as we saw in that first slide, the increase in religious exemption rate is impacting uptake across the state. We have also seen supply challenges for the new product for the RSV, for the infants and prenatal use. And when we saw the COVID vaccines go to the commercial market, there were some hiccups with the rollout on that and supply constraints. Programmatically wise, we are coming up to the end of the COVID funding and at the end of this annual year, so December, and that will impact staff that we've recruited through contracts. The last major piece that is on our radar is the cost for vaccines continues to rise year over year, and new vaccines are continually added to the schedule. Examples of this include the RSV, the commercialization of the COVID-19s, and the Mpox vaccine. We're going to take a dive into some of the data for infant immunizations to start. So typically we look at the 7 series, so it's up to 24 months. We want to see kiddos have at least 4 doses of DTaP, of pneumococcal, 3 or more doses of the Hep B, Hib, and inactivated poliovirus, and 1 or more doses of the MMR and the varicella vaccines. So this slide represents children up to date in Nevada as compared with national rates. Unfortunately, national rates only go up to the year 2020, so leaving a bit to be desired in that comparison. But we can see a 3.3% decrease in Nevada from 2019 to 2023. This is looking at the same data but broken down by race and ethnicity. American Indian and Alaska Native infants and Black infants have lower vaccine rates year over year than other races. And we do recognize that the category of unknown race and ethnicity needs work, and we have data quality staff working on adding that data component to records. Here's the same data broken down by region, so by county. As we can see, counties highlighted in yellow have less than 70% coverage rates, so calling notice there. Okay, moving into adolescent vaccination rates. Vaccines recommended for adolescents include Tdap, meningococcal, and the HPV vaccine. Currently in Nevada, Tdap and meningococcal are the school-required vaccines, and HPV is not. So looking at age comparison for the 11 to 12-year-old meningococcal rates compared to 16 to 18-year-old men ACWY is what I'm calling out specifically here. There's two vaccines. There's men ACWY and there's men B, which is not tracked on this slide presentation. But the age representation on the slide is because a child would receive the first dose at the 11 to 12-year mark and the second dose around the 16-year mark as a booster. And then I'd like to call out, according to CDC's Teen Vax View, populated by data from the National Immunization Survey. In the year of 2022, Nevada's coverage rates for 13 to 17-year-olds who have received one or more doses of the men ACWY vaccine is 85.9%, which falls below the national coverage rate of 88.6%. This is representative of the men ACWY rates for 11 to 12-year-olds broken down by county. Those in the yellow represent less than 30% coverage rates. Similarly, this is looking at the men ACWY rates for 16 to 18-year-olds broken down by county, and those less than 70% are highlighted in yellow. Looking at the 11 to 12-year age cohort, this is looking at race and ethnicity breakdown. And here we can see that Black, white, and Alaskan Native and American Indian children ages 11 to 12 have lower coverage rates as compared to Hispanic, Asian Pacific Islander, and non-Hispanic other race categories. Many adolescents are missing that race ethnicity data component, and we are working to include it in records moving forward. Similar comparison of the 16 to 18-year-old mark. This data displays an upward trajectory of this vaccine and the age cohort in all races. Important to note that about 1/3 of the teens do not have the race and ethnicity component on their record, and so that's why that other one is pretty substantial. It's also important, I'd like to note here, that the 12th grade school requirement for a second dose of the men ACWY was implemented in the 21-22 school year. Moving on to HPV vaccine rates. Children who receive the first dose of HPV vaccine before age 15 only need 2 doses, and starting at on or after the 15th birthday, they need 3 doses to be considered fully vaccinated. So these two lines are comparing the 11 to 12-year-old in blue with the 16 to 18-year-old in orange lines who have received at least 1 dose of HPV vaccine. 11 to 12-year-olds have seen a decline year over year for HPV vaccine, while the 16 to 18-year-olds have remained fairly steady. And then for national comparison, according to the CDC's Teen Vax View, again looking at 2022, Nevada's coverage rate for 13 to 17-year-olds who have received 1 or more doses of HPV vaccine was 75%, which falls 1 percentage point below the national coverage rate of 76%. This is now looking at it by county. Counties that have less than 20% are highlighted in yellow. Looking at the 11 to 12-year mark. Looking at the same data, but the 15 to 18-year breakdown. Those highlighted in yellow have less than 50% coverage rates. Moving on to the race and ethnicity breakdown for 11 to 12-year-old category on this slide. And then to the 15 to 18-year-old coverage rates broken down by race and ethnicity. Now I'd like to touch briefly on adult immunization coverage rates in Nevada. So the data sources on this slide include Nevada WebIZ and CDC's Adult Vax View. There are other components within CDC's websites for like Flu Vax View, or I think they're looking at a respiratory illness season comparison as well. So for COVID-19 in Nevada, those 18 and older who have received a current seasonal dose of COVID vaccine were at 10.4%. The national comparison is at 22.6%, so lots of room to grow. And calling out that we're coming to the tail end of the flu season, and in Nevada, 21.6 of those 18 and older have received a dose of the 23-24 flu vaccine, which is well below the national average of 42.8%. Looking at pneumococcal vaccine in 2022 for those 65 and older, Nevada ranks 62.2% of those eligible to be covered, and nationally that rate is 70%. The RSV vaccine was newly introduced this last season, and looking at individuals 60 and older for the 23-24 season, 23.6 is the national average, and Nevada's rate is 12.5. For TD, Tdap vaccine uptake among those 65 and older, Nevada is at 50%, while the national rate is 59.8%. And in Nevada, 39.2% of those 65 and older received a zoster vaccine in 2020, and the national rate is 45.7. Moving on to program priorities, we have many. Of course, equitable access is always first and foremost, ensuring that any Nevadan who wants the vaccine can access the vaccine. Part of this comes in looking at additional sources to receive the vaccine. So like the AB 147 introduced a new source for individuals to receive a vaccine. I think that's appropriate to look at other avenues where it might be convenient for an individual. And with that, make sure that underserved populations have accurate information and access to services that are needed. Vaccine confidence took a major hit through the pandemic, and so it's going to take a lot to get us back on the right track, but using trusted messengers within each community is a key source of success in other states, and that Nevada has been moving towards as well. Of course, we'll continue partnership building and strengthening. And then pharmacy-driven education. And what I mean by that is that, the link on the slide is to the pharmacy doses administered report. They put one out every year, the Board of Pharmacy does. And it seems to be one of the key sources for adult vaccination are in pharmacies right now. And so really working with the pharmacists to understand co-administration and any opportunity to not miss a vaccine so if somebody comes in for a flu vaccine but they can get an RSV vaccine with it, we want to make sure that it's being offered. Same with schools and childcare facilities. We want to make sure that they understand what reports that they are required to submit and really evaluate where their program or school stands as far as coverage and offer strategies for improvement as needed. Data quality, as I mentioned several times, is a priority for us in making sure that immunization records are complete. And of course, WebIZ, our immunization information system, is maintained. It supports our program through and through. And knowing that CDC has shared with us, we're coming into some lean years for funding, just making sure that we've got what we need to sustain that system. And then, of course, emerging threats, measles, avian flu, mpox, anything you can think of that is emerging worldwide will likely have an impact locally or statewide. Looking at what other states have done for policy innovation to boost their rates, I'll call out that Hawaii, Virginia, and Rhode Island all have HPV as a school requirement for entry, and it is reflected in their rates. They are all slightly, Hawaii and Rhode Island are well above the national standard, and Virginia's policy only speaks to female receipt of the HPV, so it's slightly above national. Other states, including Vermont, Oregon, and Utah, require education when a parent submits a vaccine exemption for religious, and that can come through a certificate from completing an online module or having their provider sign a piece of paper that they've been educated on the implications of not receiving the vaccine. And then the last topic for interesting policy innovations in other states is New Hampshire, New Mexico, and Alaska have universal vaccine programs. which combine private payers, state funds, and federal funds to pool resources to purchase vaccines, so it's not a reimbursement cost basis at the provider level. And I'd like to turn it over to Vicki.
Vicki Ives for the records. Before moving into this next section, would anyone like to pose any questions around the data-focused and policy-focused part of the presentation?
Let's go ahead and complete the presentation, and then we can go into questions, please.
Wonderful. Thank you, Chair. I just wanted to very briefly talk a little bit about the role of coalitions in public health, and then look at immunization coalitions specifically. In looking at why we work with nonprofits and community-based partners in public health, there are a number of different reasons. They can range from a requirement or a strongly encourage action by our federal funders to work with these community-based partners or coalitions. Coalitions can sometimes be a more effective messenger to reach populations of focus. The coalitions might be more agile in certain situations than government structures, and their ability to more quickly implement programs, engage community members, and change course rapidly if needed. And they can also function as an external partner to a government entity to convene partners with a shared mission and vision, to align messaging, especially evidence-based messaging, in a single message statewide to reinforce certain behaviors that are helpful for positive outcomes. And they can complement the more formal programs overseen by government entities. And then looking at immunization coalitions specifically, in terms of why we utilize those, they really help to engage networks of all different types of healthcare providers and numerous key partners to support efforts to improve vaccination rates and coverage. They provide outreach to specific communities, especially underserved communities, to improve coverage for vaccinations, and promote access to vaccines across the whole lifespan. Opportunities for immunization education to both providers, the public, to schools, to different audiences is another function of immunization coalitions, as well as promotion of vaccine confidence and timely and accurate evidence-based messaging at sharing. There's also roles in recognizing the work of immunization champions and their work statewide. But really a key piece with the immunization coalitions, especially as it's played out in the state of Nevada, is that they're not administering the vaccines, but organizing vaccination partners to conduct immunization clinics is really a key function of the coalitions. And just wanted to note, there's a national organization for immunization coalitions, the National Network of Immunization Coalitions, and that as part of our federal funding from the Centers for Disease Control and Prevention, the Immunization Procedures Operations Manual that we follow stresses the role of immunization coalitions in our work. And just noting that in addition to immunization coalitions, there are numerous boards, councils, commissions, advisory, diverse array of partners with some of these similar messaging and education roles in addition to the immunization coalition. And then just lastly, looking at what an immunization coalition does, they really provide statewide community vaccination event coordination, as opposed to direct services in Nevada, convening of vaccination key partners, and providing education, evidence-based webinars, serving as a source for media outreach and updates and education, sponsoring public health conferences focused on immunization,
public outreach and messaging, messaging on immunizations as well. Mentioning, recognizing providers who really go above and beyond in their work to increase vaccination rates or forge new partnerships for underserved communities. And items such as the Protect and Immunize Nevada's Children packets, which includes immunization schedules. Traditionally, working with all the birthing hospitals, that was an activity that has been done by immunization coalitions in Nevada. Education on how to administer vaccine, hands-on education provided by clinical staff is something that immunization coalitions do. And just wanted to note that some of the key partners that work in this space are the community health nurses with Division of Public and Behavioral Health, the local health authorities as a crucial partner in these efforts, as well as federally qualified health centers, pharmacies, providers. Our program here at Nevada State Immunization Program all work together to provide statewide services. And just again to stress, access to vaccines will not suffer from coalition service changes as they are not vaccinators in Nevada in this role. And with that, we welcome your questions. We also have acronyms and contact information for you as well. But thank you.
Thank you so much. Committee members, any questions? Let's start here in Southern Nevada. Assemblyman Nguyen.
Thank you, Chair, and thank you for that very thorough presentation. There's a lot of information, a lot of data to process there, so I appreciate the details that you all provided. In reviewing I think the last few slides on the coalition part, and you did mention that a lot of them are not vaccinators. They're truly just getting together and be able to gather folks and convene folks, right? So in terms of the recent public knowledge on one of your coalition organization, and I think I'm alluding to Immunize Nevada. What is that in terms of impact, the negative impact that will kind of, I don't know whether it's going to hinder some of the strategies that the state is doing, and in terms of oversight, what kind of what kind of things are you putting in place to prevent things like that from happening in the future?
Julia Peak for the record, through you, Chair, to Assemblyman Nguyen. I'll go ahead and start, and then I'll hand it over to Ms. Seguinus because she has short and long-term plans that we've put together. A couple things I'll just note is we had put plans in place over this last year as we were providing technical assistance in case this happened and how we were going to sustain activities. And again, Ms. Seguinus will talk about it in a second. I do want to say, honestly, probably within an hour of that information becoming public, partners from our community started reaching out from across the board. Partners with medical associations, local partners at individual hospitals, our health authorities. What do you need us to do? We're ready to fill the gap. You tell us what you need. And so that's part of it, is understanding that they filled a role. And a coalition is not government built. A coalition is grassroots built, where all these partners come out and say, we have a shared vision, we have a shared mission, we want to create something. And I'll tell you, between then and now, easily 10, if not more, partners have reached out again saying, how do I fill the gap? What do you want me to do? Is there a new coalition? We want to be a partner. So I think that will naturally occur through grassroots effort. We're also going to be supporting that. Please get together. How can we help? Can we convene that meeting to get all the partners together to talk about what a coalition looks like in Nevada for immunizations? Like I said, we do have short and long-term plans. I'm going to have Ms. Seguinus go over it. The very last part of your question, though, is how do we avoid this in the future? That's a really a big, long conversation. I think for us, we're looking at how we could change policy and maybe more intensive technical assistance. Also opportunity, I think, more broadly to better support nonprofit organizations, potentially with additional board training on On, I would say, the fiduciary responsibility, especially if you're accepting federal and state funds, there's so many strings attached and the reporting is really intensive. So just understanding that our boards understand that scope, and then can get technical assistance should they be struggling with anything, not only from us, but we have community-based partners that support nonprofits. So thinking about how that looks. So specifically with what we're going to do related to continuation of the services performed by an immunization coalition till a new one forms, I'm going to turn it over to Christy.
Thank you, Christy Zignis, for the record. Part of our short-term plans include contracting with a mobile vendor who can offer direct services both rurally and in the rural and urban regions. We'll be doing contracting with an agency who can help us do widespread messaging specific to back to school, the additional COVID vaccine recommendation for those 65 and up, respiratory illness season coming into the 24-25 season, and additional campaigns as they align with CDC's broader messaging. We're working with medical societies both in the North and the South to promote opportunities for providers to receive webinar education or seminars. Some of it might be in person. And then we're working with UNLV to continue the work of the Vaccine Equity Collaborative to not lose the momentum they've gained through the pandemic, evaluating funding for the next year for this equity collaborative, buying us time to do like Julia was saying and solicit feedback from our stakeholders across the state to inform what the next coalition should look like.
Thank you for that answer, and I really appreciate your candor in terms of addressing the issue heads on. So thank you, Ms. Peak, for your very, very anecdotal response in terms of ensuring that the technical assistant piece and with the board training. I think that's really the key, is to get folks be more accountable in terms of operating and running projects like this in the future. So I really applaud your insight on that piece about board training and fiduciary responsibility. I just want to ensure that what you said also earlier, your colleague, about messaging, that we truly embrace this opportunity also to further expand our reach into the in-language community. I know in the last session I was broken record about every chance I get in terms of ensuring that in-language access is part of your strategy in terms of messaging throughout our communities across Nevada. So I look forward to getting included, if possible, when we think about how to reach out to our communities across Nevada. Especially in my district, I represent a very large in-language community. So that would be very helpful. And then last but not least, I think, we still have a lot more work to do, and I really like to see some kind of updates, regular updates from these organizations and where they link in terms of DPPH, because I didn't even know that DPPH, and now I'm sitting in this role that I'm learning about DPPH, but I did not know that Immunize Nevada were part of this DPPH umbrella. So that was something I learned today. Thanks, Chair.
Just want to correct the record. They were a coalition partner. They're not under the DPABH umbrella. Just want to make sure that that's clear. Thank you. Assemblywoman Brown-May.
Thank you, Chair. Thank you for the presentation. I just want to clarify. In the beginning of the presentation, it was noted that there are 16 programs statewide, and that DPBH was the only one that had no findings, right? So congratulations to DPBH. But I'm curious to know, and given everything we've just discussed with Immunize Nevada with regard to fiduciary responsibilities and technical assistance needed, is there consistency that we're seeing with regard to the findings for each of the other programs that are available, that are out here in Nevada currently? And is there a way to address those issues before they become more serious?
Julia Peak, for the record, Division of Public and Behavioral Health, through your chair. Great question. And so that was part of our normal audit. There is a full report that we get for every program they audited. Again, the Nevada State Immunization Program was the only one noted that didn't have any findings. As far as how we respond when there are findings. So we try the best we can to avoid and learn from what we've done in the past. And so hopefully there aren't a lot of findings. When there are findings, we look at systemically what policies we're going to change at the agency so that there's not a recurring finding. So for example,
If there was a finding in one program related to challenges or inconsistencies in time and effort tracking. So our agency to that one has developed a shared time and effort tracking so that that one program was noted, but now it's systemic across the agency that we all time track in a certain mechanism so that if it was a finding in one, it applies to all. So that's often how we deal with the audit findings on our part. Our audit would be DPBH specific. The entities also have to do their own independent audit, and so they're not one of the 16 programs referenced here. That would be DPBH.
Thank you, Ms. Peak. And just for clarification, of those 16 programs, how many of them are nonprofit organizations? Are you aware of that?
Julia Peak, for the record, so that contract was just state agencies or just DPBH. I can confirm for you. So I don't know how many nonprofits contract with that specific company. I'm trying to think of the best way to answer your question. My apologies. So the audits are provided to DPBH when they're completed by our vendors or our nonprofit organization. So if we needed to compile some sort of information related to the audits of our nonprofits, that would be some work on our part. But what we're referencing is our agency-specific audits.
Thank you. Certainly not trying to make more work for you. I think it's just really important that we as a state walk alongside provider organizations wherever we can. I think that the state employees doing the work of the state is really good, but it also helps us, as you see, to get out to our key populations, right, when the voices are shared. And I just think that the ways that we can walk alongside nonprofit organizations or other provider groups throughout our community then will help us be more effective in the delivery of immunization in particular, right, in this conversation, which is the reason for the question that I asked. And I was just curious, with regard to Immunize Nevada, were there things that we could have done with regard to state assistance that could have prevented this from happening, right? So more on the front end than the back, that's all.
Julia Peak, for the record, great question and reflection that we've had. Are there things we could have done differently with this nonprofit? In hindsight, I personally would have liked to engage the board earlier because we were communicating directly with staff of Immunize Nevada. And so that, for me, in hindsight, is something I would probably do differently should we find ourselves in the same situation again. What I will say is this team spent hours providing technical assistance, both programmatically, how we write scopes of work and deliverables, to understanding how to reimburse. So they did site visits. We had a third party auditor, though she didn't audit in this case, come in and do the review of which I'm sure you've seen copies of. We also engaged our Office of Federal Grant Assistance, who offered numerous times to work with not only the board but the organization to provide technical assistance, and that they did not accept that assistance, though I would like to put that out there for all nonprofits. We're also engaging with the Nevada Grant Lab. That's a phenomenal organization as well, who is designed to bring in federal funds, and we've talked candidly, with that leadership about great mission and vision, and we share it, but how do we make sure our nonprofits are ready when that funding comes to be successful? So learning a lot on our part, maybe what we could have done differently. What do we put in policy? To the point of the audit, my answer earlier, is there something systemically we need to look at differently when working with our nonprofit partners? Talking with them more specifically about the reimbursement model, if that's not clear. That's a huge challenge for smaller nonprofits to work with state and federal governments. There's a lot more education, I think, that can be done, whether DPBH does it with our partners or whether, again, a bigger organization, Nevada Grant Lab, does it, Governor's Office of Federal Assistance, or if it's just available and we reference folks to go take a training. Like if you're going to get funded by DPBH, you have to complete this, your board members have to complete this 2-hour training on the process working with our agency. So we're trying to assess that right now to make sure the training is on the front end and that they're very clear on the technical assistance they can get throughout depending on the challenge that they're having.
Thank you so much. I don't see any other questions in Southern Nevada. Let's go to Northern Nevada. Dr. Titus or Assemblyman Gray, do you guys have any questions?
Yes, thank you, sir. And again, thank you for the presentation. I worry about I've heard several in the testimony early in public testimony and comments here regarding the possible need or recommendation for removing the religious exemption for vaccinations. My concern is that actually sends the wrong message out to the public, in that I see it that you as an agency and myself as a healthcare provider need to be improving the trust in the system. And when the government comes in and says, well, heck with that, we're just going to pass a law and so we'll make you do it, is giving the wrong message. And I spoke to the public health school at UNR the other day, and I was saying, as a public health person, that there's a fine line between what's best for the public and individual rights to healthcare and individual choices. And so, and I never, all the thousands, literally hours that I worked in the emergency room when somebody had an injury and I recommended a tetanus shot, they may have refused it, but said, oh, I don't know, doctor, I really need one, I hate shots, etc. I've never had anybody refuse it when I said, no, you really do need this. So I worry that you're really not gaining the trust of folks by reassuring them about these vaccinations and the importance of that. And so I'm wondering, know you're partnering with nonprofits, et cetera, and maybe having and I like flu clinics, it helps in our community, and going out to the nursing homes, it helps with that. But I wonder what's the real push, and hopefully you have some really combined effort to restore trust in the system. And I think that's really would gain you a lot more public trust going that avenue than having the big thumb of the government saying, hey, we're taking away this exemption because you aren't doing this, as opposed to addressing concerns.
Julia Peak, for the record, through you, Chair. I think it's an and. As Ms. McGinnis said, a lot of the work we do is vaccine confidence and then having trusted messengers bring that information, but also, as was mentioned earlier, doing the training with providers on maybe how you talk to your patient differently or the parents differently. That's an and. We will continue to do that. That's luckily funded and mission driven for us to have those conversations and that training. The public policy piece, we certainly research pros and cons of each, and luckily you all are the ones that make the decision about policy, and we can educate as best we can on that. But personally, don't disagree with you. I think the conversation needs to be had at all levels from a trusted messenger to that individual, and they're going to make the decision they need. We learned a lot with COVID. I'll just say we learned a lot with COVID about requirements and intended and unintended consequences. We use all that in our decision making and how we message to different groups, but certainly this group is not making a policy recommendation right now. We're just providing some examples of what other states do in that capacity, but certainly hear what you're saying.
And a follow-up to that, if I might, Mr. Chair. I'm just curious
Please
about
proceed.
the overall vaccination rates. It's my understanding that since COVID and the distrust of the COVID vaccines, the overall vaccination rates have fallen. Is that correct?
Julia Peak, for the record. I mean, it's true. Ms. McGinnis can talk specifically about any of them. I'll say I happen to oversee the community health nursing program as well that services the rural communities, and they said we've not rebounded. Like, our client level for all services has greatly reduced since COVID. So that's reproductive health, that's immunizations, et cetera. Don't know if that's happened to the larger system, but I could say anecdotally it has happened in the rurals. I've watched it.
So I would say our major charge as public health folks are restoring trust. And so to that end, I certainly am trying to do my end, and thank you for what you guys are doing. Thank you.
Thank you, Senator Titus. Assemblyman Gray, did you have any questions?
No, sir, but I would like to just echo Senator Titus's remarks as well. I think it's more about regaining the public's trust and not forcing things on them, and just taking a more gentle approach on the education side, or gentle approach on the forcing side and focusing more on the education side.
Thank you so much, Assemblyman. So I did have a few questions, more so, I'll come back to Immunize Nevada, but I just want to go over immunization rates first. Some of the concerns that in folks that I speak to that work in the health district and work in the school district and so forth. Well, first, let me start off with childhood and infant immunizations. We've talked about, so there are a lot of instances that of constituents that I hear that because we have the requirements, which obviously we've worked really we've worked tirelessly to have the vaccine requirements that we have now. Our goal should be to influence and help accept that vaccines are safe, which they are. There are students that, because their parents don't have, say, healthcare access immediately afforded to them, they end up getting suspended, and so they wait for their parent to figure out a doctor's appointment, and so now we're exacerbating the child not being able to retain the education that they need because the parent doesn't have access. So has there been any talk about perhaps looking at, and this can be more anecdotal to your experiences as public health folks, but has there been any discussion to looking at scope of practice for school nurses to administer these vaccines and maybe making it more readily accessible at the schools? Because oftentimes the folks that we trust in our communities are our community centers or our school administrators. Is that something that we could potentially entertain as a legislature? I know we've talked about other bills like dentists and dental hygienists, but have we looked at perhaps what we can do in schools?
Thank you, Vicki Ives, for the record, and thank you for the question, Chair. In surveying different options that other states have looked at specific to scope of practice and school nurses, the literature isn't very robust, honestly. There's a wide range of ways that the state-to-state laws vary around school nurses in terms of immunization supports. The National Association of School Nurses really, they have some particular pieces that they stress around best practices, such as school-located vaccine clinics and the elimination of all exemptions except those necessary for valid medical complications. But the Academy of Health really stresses the variability in how no state currently authorizes nurses to conduct all elements of immunization practices for all age ranges in a school setting, and that expanded authorization of nurses in all states could increase vaccine administration rates. And school-based nurses have a unique first line of care touch point there. Standing orders programs are mentioned in this context as well, and as a way to increase uptake of vaccination. And there's a legal foundation around authorizing delegation of immunization services performed by different types of providers in broad population, patient populations in different settings, and sometimes the engagement of non-physician health professionals. There's been a number of pilots in the UK specific to HPV and school nurse vaccinations, they've found utilizing certain types of electronic consent has helped. Not in some cases, it's helped uptake and speed of getting those consent pieces taken care of, and in others, it's just the speed of getting the consent in and not necessarily higher uptake in looking at that nationally. But it hasn't been, I'd say, a focus of the Nevada State Immunization Program to date, and the Department of Education and would be a key partner in looking at that. But, Nevada is one of not all states have. We require some additional educational coursework to receive and maintain a school nurse certification, in addition to the RN license. So there might be opportunity there. But those are just some of the areas of opportunity. There's also Massachusetts does actually designate their school nurses as public health authorities, if that's of interest, in granting the authority to obtain immunization information directly from healthcare providers in their statutes in order to monitor and ensure compliance with immunization requirements in schools. So there's some pieces focused on health information exchange and access to school nurses as well. That have been an area of focus. So those are just a few elements in that space in case it's helpful.
Yeah, I would love to see that legislation from Massachusetts. I think my perspective, and I don't know how my committee members feel about this, in parts of, we talk about infrastructure and access to healthcare and service providers that can be trusted by the communities. And schools oftentimes are the first line of resource for many of the folks in the rural areas or in parts of Clark County that parents have access to because there is that touch point. And so it would be certainly interested in seeing what we can do to reform the delivery that school nurses can be a part of. I know I've heard concerns of how can we reform and standardize what electronic consent can be for parents should the parent decide that they want their child to receive certain level of healthcare services, whether it's immunizations or other services through their school facility. I know we've piloted in CCSD telehealth and so forth, and so it'd be interesting to continue to explore that. And then obviously universal vaccine coverage. By any chance, do you happen to recollect how much money has been expended to those types of programs in other states?
This is Christy Zignis for the record. I did not deep dive into the funding amounts, just the structure of how it came to be.
And my understanding of that policy is we as a state are going to purchase these vaccines to be administered so that folks don't feel the challenge of having to pay for it. We're just trying to encounter and make sure that the service is there to be delivered for people who want it. Is that correct?
Yes, this is Christy Zignis for the record. 2 of the states I mentioned only cover children, and Alaska goes up through adults, but exactly what you're saying for the purpose and intent.
Great, thank you. With regards to Immunize Nevada, I think, some of my colleagues kind of alluded to this, and I think the main question that I had was, I know that the articles alluded to contractors being paid or not being paid. Have we heard of any complaints from staff members also not being paid? And feel free to push back in case I know some of this is subject to investigation, so if you're not able to answer that, I understand, but are there any reports of staff not being also paid from?
Yeah, Julia Peak for the record, Division of Public and Behavioral Health, to Chair. The article, I'll say, mentioned my name, and so I've had a number of staff members reach out to me, and I honestly communicate with them daily about challenges with payment for a long period of time. We have encouraged those staff to apply for some jobs with the state, hoping that we can get them into state employment. We have encouraged them to reach out. What was that agency that you reached out to?
Oh, the Labor Commission.
Oh, the Labor Commission. My apologies, Chair. Connected them with a Labor Commission to follow up in that realm. Also serving as a bit of a liaison between them and Immunize Nevada to try to help them get information on when they should expect payment. But that's a difficult outcome, and these folks have, in some cases, not been paid for a period of time, and that's their livelihood, and it's really unfortunate, but have been communicating, like I said, with several daily.
Yeah, and do you know, by any chance, are there other organizations, not contractors, not staff, that haven't been paid, from your knowledge?
Julia Peak for the record, Division of Public and Behavioral Health. Some organizations have reached out to us directly, indicating that they have not had payment for a period of time, as part of what you probably read in our recommendation letter, because we were only aware of a few, and we're certainly not the entire budget of that organization. We asked the board to do a deep dive and figure out what your expenses have been, what has been paid, not paid, et cetera. But as you're aware of with the article, a number of those board members have left, but that we think is a very important exercise because, again, folks are reaching out to us, indicating that there has been a period of time without payment.
So I appreciate those comments. Let's talk about the short-term and long-term strategy. So it is my understanding that this coalition partner was responsible for a lot of the outreach efforts in the rurals where our government, right? Like as you alluded to, there are certain services that the government is entrusted to take on, and then we partner with coalition partners to continue and extend that work. So now that there has been a gap identified, what are the short-term and long-term plans that you guys have in action? I know you alluded to it a little bit, but maybe you can just reference it again.
Yeah, Julia Peak for the record, and I'll hand it over to Ms. Again if you'd like her to read that. But I'll note part of what we shared is that they are the messenger, the convener of those events in the rural communities. My nurses are also out there. We have county health officers that can promote the events. The health districts can promote the events. So I do not see a lack of promotion of the events, especially with all the partners that have stepped forward. As Ms. McGinnis noted, we're going to have a vendor who will be providing the vaccination services, so we're just going to promote those and work with our community partners in that community to continue to promote those. We're also going to be working with a different outreach company that we worked with in the past who did a great job in promoting those events. So it will just be making sure that we fill that gap in promotion and convening, but have been very excited about the partners who have stepped forward and said, you just tell us what you need, we're going to do it.
Yeah, and then just last question, in terms of the infrastructure that you have statewide, how many staff members do you currently have to run immunizations?
This is Christy Zignis for the record. I have 16 state full-time employees. I have 26 contracted COVID employees and a couple other funded sources, but less than 5.
And I'm assuming the goal is to keep all of the ones that are COVID funded so that over time you improve your infrastructure, correct? Kind of the message we've heard all day today.
Christy Zignis for the record. Knowing that the COVID funding is going to end at the end of December, right now is when we are prioritizing the efforts that the COVID staff have done to see what we can maintain.
And there's certainly enough work to be done to repurpose them if we wanted to, correct?
Definitely.
Julia Peak for the record.
Okay.
Sorry, I'm going a little hoarse now, but Julia Peak for the record. I think one of the most important things that was gained during COVID, among other things, in the Nevada State Immunization Program was the staff around data modernization and ensuring that the WebIZ system is successful and accessible and all of those really important activities. That is some of the staff that could be lost with COVID funding, and that's where we go back to the conversation earlier about what are some of that, if we were to get a sustainable general fund investment,